F. Now coming to H reflex. Okay, so here you can see different gains or sensitivity. Again, this is H reflex. So here, ideally, it should be less than 32.5 millisecond for lower limb and 15 or 16 millisecond in upper limb. So it is more or prolonged here. Are we clear? Then EMG, electromyography. Again, the same graph paper, large square, small square, large square of 1 centimeter square. One large square will include 25 small square, etc. So here the unit measurement is sensitivity or gain is 100 microvolt. Means vertically 1 centimeter is your, how many microvolts? 100. Okay. Whenever it is microvolt or millivolt, it is vertical. Whenever it is millisecond, it is horizontal. Almost all the graphs in physiotherapy and even engineering, they are intensity versus time curve. Like in physiotherapy, strength duration curve, stress strain curve. Okay, all these are intensity versus time. So intensity means millivolt or microvolt. This time means millisecond. Fine. So here you can see this potential covering 6-7 squares vertically. So it's of 700 microvolts. So it's normal. Normal value we need to remember. Okay, that is from 300 microvolt to 2 millivolt. So it is normal here. Fine. So this is sweep and sensitivity wise, we have assessed the triceps. Now for facial muscles, so they are very small muscles, so they will give very small potential. So accordingly, their normal values will be also different. So this is how we can interpret the voluntary activity of EMG. Spontaneous activities, there are many. Spontaneous activities means when the patient is not performing any movement and still you record some activity. Okay, so spontaneous activity itself, it is abnormal, irrespective of its type. There are two exceptions like end plate potential and patient is not relaxed, but that may be ignored when we are in learning stage. Fine. So appearance of spontaneous activity itself, it is abnormal. But when the patient performs voluntary activity, this kind of the potentials are seen. But just by voluntary activity, active movement, we can't conclude everything. We need to give resistance also. That is known as interference pattern. So one is without movement, that is spontaneous activity, then with movement, that is voluntary activity, and one is against resistance. So when we offer the resistance, fast twitch fibers will also come into action. So that we are recording in form of interference pattern. Ideally, this background, white background should be totally covered by this black graph. Here it is black one, in different software it is different color, but ideally it should be covering whole screen. Okay, so that is very good interference pattern. Summary, very simple, traditional use wise. If we go strength duration curve, what we do, it is giving us status of muscle. If we go for Faraday galvanic test, it gives us idea about the motor nerve status. Fine. But now we have many options like evoke potential. So uh, that will be able to diagnose the central nervous system dysfunction. Then H reflex. So that is proximal root lesion. That is radiculopathy clinically. Fine. So H reflex will give you idea about the proximal root, but sensory. F wave, the same thing, proximal root dysfunction, but at motor level. Then comes SNCV or SNCS, sensory nerve conduction study or sensory nerve conduction velocity. So it is assessing your sensory nerve. Motor nerve conduction study or motor nerve conduction velocity, it is assessing your motor nerve. So NCV or NCS is for peripheral nervous system dysfunction. Evoke potential is for central nervous system dysfunction. F wave and H reflex, they are late responses. Those are for proximal nerve root lesions, okay, where they are meeting between the CNS and PNS. Then EMG, so that shows the status of muscle, and RNS, that is for neuromuscular junction. Okay, is this clear? Fine. Any question?
Can we have two questions from the audience?
Okay. Any question?
Okay, thank you, sir.
Okay.
Dr. Ash.
So this lecture was prepared from this book. So these are the references. You can see more of my lectures from YouTube. Sometimes you need to add the word Ashish Kakkar, physiotherapist. You will get many of my recorded lectures. Okay, thank you. Thank you,
Thank you,
madam.
Dr. Ashish, for a very insightful lecture. It's
Thank you,
very,
madam.
very important for all of us to learn. Take back lots of good points from. Thank you so much for
Thank you,
that.
madam. Thank you, both of you.
You'd like to felicitate our speaker, Dr. Ashish Kakkad, sir. Our next session would be chaired by Dr. Deepa Metkud, Professor, Head of the Department of Pediatric Physiotherapy. She has conferred multiple national honors, including the VT Nasima Gold Medal, Best Teacher Award, and Outstanding Excellence in Higher Education. She has received prestigious recognitions from IIP, including the Significant Contribution Awards and Scroll of Honors. She is also awarded the Best Scientific Paper at national conferences in 2005 and 15. She served as principal investigator for major national and international neurodevelopmental research projects funded by NIH, WHO, ICMR, and global universities. She has contributed extensively as an editor in chief and editorial board member for leading physiotherapy journals and also has been invited for numerous talks at national and international conferences, including the WCPT Dubai 2020. She also holds granted and published patents in pediatrics and rehabilitation technology. Welcome you, Dr. Deepa. We have another stalwart in physiotherapy, Dr. Amitesh Narayan, sir, who is a professor, Kasturba Medical College, Mangalore. Sir is a AACPMD grant, has received, that is from Feb 15 and 16. Sir has one patent application, copyright granted are three. Sir is a consultant specialist in physical therapy, Department of Rehabilitation, King Fahad Armed Forces Hospital, Jihad, Kingdom of Saudi Arabia. That was his tenure from 1999 to 2021. Sir is a member, editorial board, critical reviews in physical and rehabilitation medicine, Bigel House Publishers, and Sir has peer-reviewed research papers, has published in various journals and a few non-indexed. But to his credit, we have 49 publications. So we welcome you. Our next speaker is Dr. Asha Chitnis, ma'am. She's the owner and director of Vedanta Pediatric Center. She's pursued her bachelor and masters at IIP MR Mumbai University and has extensive experience treating individuals across the lifespan with neurological challenges. Uh, we welcome you, ma'am. Stage to you.
A lovely morning to all of you. And I think so at the outset, I need to thank the Pearl Conference Physiocon to invite me for this August conference. What I'm going to speak in the coming 30 minutes is something that's very close to my heart. And I'm searching answers for that. We don't really have answers. What I'm going to speak about is navigating transitions from childhood to adulthood. What are the challenges and opportunities our kids with cerebral palsy face in life? I think so. You all know that cerebral palsy is a condition that has survived and outgrown pediatric rehab, but yet forms the largest chunk of physical impairment. And I think so. This is a field of rehab when I started my practice did not exist decades ago, but right now it needs a lot of innovation and attention. So, for this 30 minutes, the thought of your day should be the adolescence of 2040 is a 3-year old that I and you treat. How do we prepare them for this lifespan? It's extremely important to understand. I mean, if I really look at backgrounds, I'm not interested in what America does or what Australia does. But look in that yellow, it's a sad state of affairs that if you really do any kind of review and find out, I don't even in our country have a data to tell me that we have so many kids with adolescents or so many kids with adults with cerebral palsy. Hence, what is transition then? It's not about transferring care, it's a part of transferring care, but it's not, I mean, it's a single, not a single event, but a multiple events. That means you transfer their health from one organization to the other, and it's very, very challenging. 15 years back, I would not stand on any podiums and talk about it. As I have grown in the field of physiotherapy, it makes me realize what we are facing in this country today. I went through to do a lot of, I'm not a research person, I'm an absolute clinician. But I went ahead and looked at lots and lots of reviews of literature. If you really look at them, there are very few articles on transitions, none in India, unfortunately. They are emerging, but nothing that's available in the space of research. But remember, there are two important things. Neuro rehab, there were articles around 1800 in pediatrics, but on neuroplasticity and pediatrics, which is very critical as I talked through my presentation, there were 30,000 articles. And the challenges that I and you as therapists face today in our clinical practices is we have lack of understanding of these kids, what they have gone through. We are not really trained as yet to understand as pediatric therapists that area is so gray. Even the parents and the children who are adults and adolescents don't know or will never discuss this transitional process. Today in India, you are all aware that hospitals are not equipped to accept kids after 18 or 21, depending on where all you practice. There's tremendous problems with isolation, financial burden, functional rehab skills like vocational skills and life skills are missing as much that that population requires, and even education. Hence, what we did was we did a very unstructured interview. We took two groups. What we did was, excuse me, we took parents and kids with cerebral palsy, and we only picked up classification MAC, all systems as 1, 2, 3. So when I say this, kids and adolescents and adults were verbal. And the questions that I asked them, they were between 18 and 25. I'm summing up because of lack of time. But look at the first question. Were they even aware of governmental schemes? The answer was no. Were they even explained what it is to transition that by 16 and 17, you may not even meet your pediatric neurologist if you're going to this particular hospital? Were they prepared? The answer was no. They were also not really aware of who would be their providers through that span that they go through. And were they, both parents and children, aware about all the comorbidities that me and you go through in aging? Were they really aware, or were they explained what happens to them differently? The answer was no. The second group was we all, multidisciplinary team. And I tell you, it was surprising when I spoke to all the pediatric therapists on the interview. Nobody understood what is physical fitness, what is the problems, medical and musculoskeletal problems they face, how much of fatigue and endurance is such a challenging part in their lives. Not me, not them were even aware of governmental schemes if they were alive, if they were possible or they were not possible. And did they really know who their team was? Even today, when I speak and stand, we don't have transitional OPDs. I think so. The need of the hour, when I spoke 25 years back, was early intervention. The need of the hour now becomes transitional OPDs everywhere, where parents access. That is such an important part. Neuro rehab, I think so, is so exciting because we live in a time of great change. I think so, there's so much of development in neuroplasticity. There is a lot of basic research that is going on in understanding the muscle pathology and physiology of kids with cerebral palsy. And technology and AI is just taking the market by storm. So that's what we really need to encompass about. Now look at those little circles that you see. That's the child that stands in front of us. Did he have a damage? Yes. Is he having epilepsy? Yes. Is he on medications? Yes. Have someone got through surgery? Yes. Does he have cognitive delays? Yes. Does he have social inclusion? Yes or no? Does he access school or college? We don't know. There are hormonal interactions. What is his support? What is his motivation? What are his challenges that he faces? Plus, the most important thing that I'll touch when I go is sex education, how important it is and where should it start. That's another challenge. So look at these gamuts that that child faces. And why I bring this out is I guess we need to be empowered to understand every small circle that is present. Now, look, what I found out is what happens in adolescent's brain. Three things. White matter increases, your gray matter decreases, and look on the right side, there are many changes that happen in the prefrontal cortex, the amygdala, that's your memory and fear centers, and hypothalamus and corpus callosum. And remember the first principle of neuroplasticity. If we don't encash on this, use it or lose it is really completely lost. There's a lovely study that I picked up from one of the books of neuroplasticity, and it says that brain development during adolescence is really not linear. And what really came out of that was that there is a huge correlation between frontal, that is your executive function, and your limbic and arousal systems. And that is why the change in behavior is seen in a lot of children that you face challenges with. And another point that came out, your brain is developing at 12, 16, and 21. But look, the study was totally different, but so important. It said that teens who start drinking by age of 13 have 43% chances of being alcoholics versus who start drinking at 21 have only 10% chances. What I want to bring out here is how much we need to really tap this area and this age for getting the best out of what is happening. I tried to do some review of literature, didn't find anything in the Indian scenario. What really came out were two things: pain, fatigue, quality of life, and decline in gross motor capacities. This paper talks about what was the decline. So the decline is there in gross motor capacities of walking. There is pain, there is weakness, and there is fatigue. The second, this is a very nice paper where they really looked at in 2017, they actually did a retrospective study of 5,721 people. The ages were from 10 to 25 years. They had diagnosis of spastic quadriplegia. 70% could use their hands. The question was, do we lose ambulatory processes? And what happens in the future for such children? If the results, I sum it up, that kids who are in the classification systems of 1 and 2 have not had much decline. But anybody who's 3, 4, and 5 have the greatest, the decline starts at 7 to 8 years, but the greatest decline is seen in adolescence. This is very important for us to understand because it then tells us what we need to do as therapists. And also another point that came out is different kids with different tonal classifications of cerebral palsy are going to have different progressions. One more point I want to bring out, guys, it's very important as therapists here, that if you understand the classification system, the GMFCS3 will review and will require intervention at 50% of them. And 4 and 5 will actually show you lots of hip subluxations, spinal scoliosis, or kyphosis as their deformities. We looked at physical activity in adolescence. I think so. This is a window of opportunity for we as therapists. How do we literally treat them? This is a great article that I read. It says that 65% were physically active and only 56% did exercise. Guys, Being fit for us is important, but for them is much more important. I think so. We as therapists need to really emphasize on fitness. Those fitness things do not happen in our clinics. So our thought processes will need to change. This was a paper about socio emotional behavior. That's a big part of adolescence and growing up. And what it said was that they had tremendous problems with internalizing themselves. Anxiety, depression, aggression were the key factors that we really need to deal with it and also respect it and understand that they went through it. What was there was another paper which I picked up at 2011, and it was saying what is important for someone between 13 and 19 years exploring. And I think so. These were the highlights. There were 144 kids studied, and it said that they needed more opportunities for paid employment. They also wanted the first two are very important: leisure activities, social involvement, sexuality issues came out so much when I had chats with mothers and adults also. Their transfers and accessibility were their biggest challenges that they face. When we did a quality of life adult paper that I saw, it actually speaks about what they feel and what is required of them to what is required of us to do, and how do we correlate that to participation and functioning. Then another paper that came out was talking about again the quality of life, and they did lovely domains. And what they talked about was this, and I think so this is an eye opener for all of us as therapists. They talk about their physical health, their mind and spirit. They talked about family, friends, and fun. They wanted to access the world, so technology. They needed skills for life, and they wanted to contribute in their education. Pain, my God, that was the papers that I got enormously. Remember why I bring this out. 75% of youth report pain. Where is the pain? Shoulders, back, and knee. That's very common. The other thing that stood out for me was stiffness and fatigue. And all of these were very important. And why I say this is, I think so somewhere as pediatric therapists, we will need to really collaborate with musculoskeletal therapists with pain and understand how we could help them. It's just not about medication. And so, and the last thing that I've looked at is osteoporosis. 77% of non-walking children are liable to have fractures, and the statistics was about 4% per year. Do you understand what it is by just having one fracture and immobilization creates so many problems for our children? Now talks about what we do. I think so. We need to understand and answer as therapists. Guys, the biggest message I want to give you is you can't call them every day at your clinics and do a program. We need to think out of the box. And I think so. What we need to understand is in the early years, we can call them. But what you do in your early years is so important to address and prevent the functional declines that they face absolutely in their life and the long term implications of it. Having said that, the role that we all as pediatric therapists play potters in ICU, school age, and adolescents. Guys, this is something that I want you all to remember. When you start looking at kids, you know ICF is taught in your clinics, but put it in this way. Your body impairments is fitness. Think of fitness, guys, right from the beginning. How important is participation and function? Think how important is fun in them. There is no fun. There is enough research that if you really teach it with fun, the chances of them learning are much more better. Think of the future and think of the family that is a part of your therapy group that goes through it. I think so. This is a slide that sums it up, guys. Look, when you look at a girl at a year, to a guy who's 18, if you don't take care and understand those little tightnesses, which are limitations as your impairments, will become a huge problem, unguarded, unsupervised, stand up into scoliosis and kyphosis or hip subluxation. So common in a lot of kids that we see. Also understand this as therapists that when a child comes to you, 0 to 5 is aspirations and hope for parents. But as they get into adolescence, they hate to be in therapy. You need to reinvent your wheel and say what they need to do. And I think we need to reevaluate them. Our interactions have to be very different, and we need to respect that emerging mother and the child that is in front of us. Also, an important point to make is if you are treating a child who's 8 years with old, 8 years old with spastic diplegia versus a child with dyskinetic cerebral palsy, the role, the environmental context, and the interventions are going to be very different to understand impacting their lifespan. This is a very important point for therapists. See what it says. If you really look at this, was a study done by Peter Rosenbaum. It is an Ontario growth motor growth. It's a great prognostication. They took 700 or 582 kids and they plotted it between age and GMFM 66, which is an absolute outcome measure for participation. And what they said, if you look at the if you really look at the doesn't work, it doesn't matter. But if you look at level 1 and level 2, those are the kids we had GMFCS 1 and 2, they not decline. But if you look at the ones in the blue, purple, and the light, dark blue, they start declining, guys, by 6 to 12 years. That is not changeable. It's a fact of life. Hormones, puberty, growth, multifactorial regions. And that is why the goal setting that we have to do and think what how it will affect is very, very important. The other thing is there is a book written by Dr. Karen Pape from Canada. She's a pediatric, she's no more, but she's a pediatric neurologist who wrote a lovely book says a child can run but cannot walk. What she came out is the same period that 6 to 12 is where the neuroplasticity declines. And I think so because they go through these growth spurts are very, very important. Our job is to motivate a mother and a child, prevent distortions, and maintain the alignment. I talk to all the pediatric therapists. You can't mess about alignment, base of support, and center of mass. If you do that, you're giving them a fantastic salad of many deformities that is going to happen to those children. So function, function, and function is the need of the hour, and that is what is going to work. So what I want to show you is swimming is a great activity to add into their repertoire for developing endurance. Playing football with peers, if you can maintain that alignment, is important. Nobody is going to come to my clinic and get strength. Looking at what best they can do in a fitness program. Can she walk on a treadmill? Can she use an elliptical? Can she do some weights? Looking at that alignment is going to be more beneficial than she coming to the clinics for just a routine therapy. Also, guys, whether you're an OT, whether you're a PT, whether you're a speech therapist, I don't matter. But what really matters is to teach ADL skills. And also, rather than doing pegs, you see what we are doing out here is teaching him a tap to communicate to his parent to call if he's a non-verbal child. These are more goal-oriented activities, and this is what you require. Lastly, adaptive mobility equipment challenges are huge. We routinely say anterior walker, posterior walker, crutches, cord canes. Guys, look at their postures. These are the same kids who come back with shoulder pains because of standing atypically. So planning a correct adaptive equipment to use for mobility and a chair is very, very important. I think so it's better to prevent than to give them pain as they go through their lifespans. Technology in rehab is emerging. There are three aspects to use it for assessment, monitoring, communication, or treatment. I think so right now for a lot of my kids, if you see these are all the kids that I've treated, cognitive rehab is superb where you can see someone using a Toby to communicate with WhatsApp. Look at that big mouse where she can talk in school. And also look at this child who I've treated in his 20, just passed his 12th exam. He would type and the teacher would speak. This is where technology is really booming and it has to be used to get their best participation. The other thing I want to talk about, both this is another adult who interacts. There are these chat box. With Youngistan is called that chat box where they do group sessions of dancing, Sanskrit shlokas, cooking. This is how they all talk about. This is a girl that I've treated through the lifespan, and she's allowed me to show these videos to you. But she's so enjoying her social peer interaction that she does. And lastly, speech. There is a lot that has happened in technology about speech where nonverbal kids can communicate with you. And I think so, as therapists, we are PTs who see them very early. This part can never be forgotten, and it has to be introduced very early in life. Sex education needs to begin at home. And I would suggest that these issues need to be talked with your parents. If you think you need to refer them out to psychologists and psychiatrists, do them early. I always refer parents at 3 to 4 years to understand what's going to be required of them. Menstruation and cerebral palsy has to be discussed. You need to talk to your gynecologist with the mother. What's the plan for that child? And don't forget, lastly, the parent or the caregivers, physical, emotional, and mental health. It is important because they are my primary therapist. And lastly, if you don't know, get empowered. Legal guardianship is available for all our parents. Putting them to the right social worker and the lawyer is the need of the hour now. Otherwise, suddenly, if a parent is gone, children are absolutely left unattended. As I finish in 2 slides my presentation, our goal as therapists is to build personal capacities, reduce environmental barriers, give them lots of environmental support. And I guess as a therapist, I need to reassess my goals throughout and remember that too much of expectations or too less expectations should not breed a lot of problems. Two things I want to say: there are many gaps in transitional care in India. There are four concerns that I have. There is security for long term relationships. There are hurdles, navigate, and logistics of transition is a problem. There is huge difference in pediatric and adult care, and we yet don't have great providers and expertise in adult sitting. If you look at the last thing, go to the National Trust, we have so many schemes for children, but there are no schemes for kids who are going through adolescence, transition, and adulthood. The unmet needs, if you just look at what I've said, whether it is mobility, whether it is positioning, whether it is bone and joint, and whether it is pain, it is huge. So unmet the needs are for our children during transition. I think so. When I conclude my presentation, we need to improve our practices in understanding the neurobiological basis of CP, still limited. I think so. Societal barriers, assessing comprehensive adult service are still the rule that expectations that are required. Our aim is to provide active participation and wellness, and we as therapists need to do regularly absolute good assessments and think how we can prevent functional declines. So, my message to all of you: I want all of you to really think of this population, start planning about what you can do as therapists. How can you contribute? Because it's a holistic approach. Health, well being, and social participation is needed, which values and desires of the individuals are concerned. Thank you so much for your patience. Thank you so much.
Thank you, ma'am. I request the chairperson.
A very warm welcome to all of y'all, and thank you, Asha ma'am, for this wonderful lecture on transition of children of cerebral palsy into adolescent. I think ma'am has touched upon all aspects, like in adolescent, reduced mobility, reduction in endurance, musculoskeletal problems increasing, pain as a main factor, sex education, socio-economic, socio-emotional problems in them. So I think ma'am has touched based upon all the aspects that are required for a CP child who is going into transitioning into adolescent. Ma'am, I have a couple of things that we would want to know. How important is um, yeah. How important is emphasizing on education in these adolescents when we know that their early years are not into schooling, they're exclusively into therapy only. So there's no emphasis on schooling. So should we concentrate on education in adolescent or just leave it?
I think so. She brings out a very important question. And if anybody has worked with me or heard me say, for me, education is number one because part of my social participation starts there and then comes therapy. I mean, I do not want any mother to miss school because I or other therapists don't have the time to give her. I want that child to go to any kind of school where that child participates. I mean, there is no way that you can lose that part, and it should start way early. We send our kids to play school. We really request. And I think so. What I want to say is wherever you work, guys, go team up with the teachers, explain them. Those teachers at school don't know what to do with children. Help them to sit, help provide them everything. And I think so. Once you do that, it's a game changer for our children. Very important. Deepa, very important.
Another thing is about pain, ma'am. Pain in these children, be it pubic region pain, menstrual pain, or because of the musculoskeletal problem because of their growth spurt. So we as pediatric physical therapists, do we have an awareness? How do we create awareness about pain education among parents as well as therapists, and how do we manage them?
I think so. There are three questions that she asked. Awareness is very important. And I think so. Yesterday, when people came to the course, once you know what your classification system is, and when you know that the child is going to get involved, the first thing I want the child to have a proper adaptive sitting. So we don't mess up with the alignment. We don't over elongate any muscles or shorten any muscles. So, and explaining a parent that this is what can happen, also making a mother talk to a mother who's gone through that becomes absolutely a barrier that is broken so easily than coming from me as a therapist, that oh yes, my child has pain now, we did this and this was not correct. So I make a lot of mothers become advocates to speak about pain for parents who've gone through it, and for parents who are just beginning their journey as a parent with a child with special needs. So that is one. I think so. Best is, because in my career, I have not learned how to use pain modalities. I always talk to a musculoskeletal therapist and, if required, take and seek their help because they're experts in pain. You can't become an expert in everything, and everything is not ice, everything is not hot pads. What you really need to do and what requires to be done needs to be done by collaborative approach. Very important.
Thank you, ma'am. Thank you so much.
I think Dr. Asa Chitnis ma'am need a standing ovation from all of us because she has put in her years of experience in her presentation, which is possible only when somebody is so dedicated and working with full conceptual thought process, mixing the academia and the clinical in the forum of this academic presentation. Thank you so much, ma'am. And what she has highlighted is we have paid attention for the younger children in terms of early intervention. And she has actually mesmerized us that not only young child, but as you transit to the adulthood, they also need early intervention, but in a different way. Just to add, what we know is that as a normal individual, the aging sets in by 28th year of life. And after 28th year of life, every decade, our brain reduces blood flow by 1%. But in case of challenge children, that depletion actually begins what we have seen clinically is by 17 or 18 years. Now, in this aspect, ma'am, you highlighted the role of technology and rehabilitation. We would like to know from your clinical experience so that our younger generation audience can get the idea as the technology is improving and the body is growing with the challenges of the brain. How do you think that we can add the technology for the benefit of these growing children who has brain damage? Thank you so much.
Yeah, I think so. Very important. And I think so. Last year, Scientific Eye spoke about it. I'm not saying that hands on therapy will ever go away, always here to stay. But I think so. What we need to understand of what he says is how could you collaborate with people who can help you with technology in terms of number one, if I'm actually working with an IIT group, if we can have a smart watch which looks at postures of parents, of children at home for that mother and for that child, my alignment is sorted out. If I can just empower that mother, do you realize if I do that at 1 year, that child who's going to be 20 in 20 years would have a different quality of life? So I think so. There is technology today that I'm using is for cognitive and speech much more than in terms of the other technology, but it is coming. What we do basically is you have to look at a child, individually look at what is required. You can't just say, okay, vibration therapy, virtual reality will work for every kid. You need to pick the child, who that child is, and be very cautious of it to be the correct uh, mode for that child. It is coming, it is emerging. My message to all of you is AI is here to stay. And I guess we as medical professionals, paramedical professionals, need to know that I'm not saying it's going to replace medicine, but it can replace all of us who don't use AI. So that is what you need to understand. But I think so we need to have the discerning power, what to use and what not to use, and for whom, how to use. But it is 100% coming. What is happening for our kids in adolescence? We have lots and lots of apps that can tell me scoliosis, that can tell me hip subluxations, that can tell me SATCO has come out that if the child is at this can happen for trunk control. Those are the things I will definitely use for technology.
Thank you so much, ma'am. Right, I appreciate it.
Thank you so much, everybody.
Thank you very much, ma'am. I request the chairpersons to present a token of appreciation to Asha Chittis, ma'am. I request Dr. Santosh Medkut to present a token of appreciation to our chairpersons, Dr. Abhitesh Narayan, sir, and Dr. Deepa Medkut. Thank you. Our next session chairperson, I request Dr. Professor P.C. Swain, sir. I request Dr. Ravi Saundatti to please come on the dais. Sir is a professor, STM College of Physiotherapy, and holds an experience of 20 years and 10 years post PhD. Welcome, Dr. Ravi. I request Dr. Prashant Mukanaur, sir, to chair the session. Sir is principal, Kelly College of Physiotherapy, Hubli. It's also a constituent unit of Kelly Academy of Higher Education. Thank you, sir. Our next speaker is Dr. Diana Pinto, who's the owner of Nutrition and Pain Management Clinic Thane and a teacher at Maharashtra Acupuncture Council, India. Madam is a physiotherapist, gut microbiome, and sports nutritionist, personal trainer, SNC coach, and certified dry needling instructor with licenses in India and USA. She holds an MNC in biokinesiology from USC, USA, and multiple international certifications in dry needling, acupuncture, nutrition, taping, Pilates, and life support. She runs a physiotherapy, nutrition, and pain management clinic in Thane since 2012 and is a published researcher with ongoing clinical studies in dry needling, shoulder conditions, and osteoarthritis, has delivered more than 100 national and international lectures, and is a recipient of multiple awards, to name a few: Best Physiotherapist Bharat Gaurav Puraskar in 23 and Miss India America in 2009. We welcome you, ma'am.
Can you hear me? Hi. Good afternoon. I think it's morning. Good morning. I'm Diana Pinto, and I'll be speaking to you about dry needling, and any kind of queries you may have are welcome. What we'll be talking about is how dry needling can be one of the tools in your kitty, which can help you enhance your practice and improve treatment goals and outcomes for patients. So we'll begin with, I'll need help with this, please, because can you please help me with this? I have to navigate it from here. Right. So most of you all must have encountered patients. There are patients who are always in pain, or patients whom you all like to call psychological disturbed, and nothing can be found on blood tests. Nothing can be found anywhere else except the patient is complaining, and the patient is possibly just somebody who likes attention. Or else you'll find that the patient is not very well rested. So if there are patients whom you give treatment strategies like a simple exercise program, and despite that the patient is not improving, no matter how many times you've exercised, no matter what you've done, the patient is always in pain. You have to understand that there is something beyond and above that we don't understand or we have not studied, and it is important to expand our avenues to incorporate those different strategies that will work for that patient, and not really judge a patient or come to a conclusion that the patient is wrong when in fact we are limited by our own beliefs or our own skills. So what I'm trying to say here is try to look at all different patients as an opportunity to learn something different. When we look at patients who are tired or depressed all the time, patients who have multiple deficiencies on their blood tests. Again, blood tests are supposed to be a way in which you can look into one aspect of a person's health. They should not be the sole method of treatment for a patient. So when you get a vitamin D deficiency, do not look at it as something to give 60,000 units of vitamin D supplement at once. You have to look at it as possible way of having vitamin D resistance. It could be caused because of 1,000 different reasons. But the point is, do not look at blood tests as something like a hole to fill in. You have to take it as one aspect of treatment only. So pulling ourselves back, these are all different kinds of patients that we can encounter. And I will limit myself to dry needling today. But when I work with dry needling and nutrition. I work on the human microbiome. I work on certain aspects of genetics. I work on certain aspects of stress, anxiety, sleep. When we work on all of those aspects, patients tend to heal faster, better, because the body does not work as one unit where it's only gynecological conditions or only orthopedic conditions. Even your muscles are part of your immune system. So if you look at everything, if you look at the structure as a whole, you will see that patients improve a lot more faster rather than segregating them into different parts and units. So moving on. Okay. So coming back to what I was saying is that physiotherapists can sort of become like a one-stop solution for a lot of problems that patients have. If you can work with acupuncture and nutrition, you can improve a patient's sleep status. And sleep is so restorative. Sleep is so wonderful and beautiful in the recovery process that you will have a patient working harder and better in their exercises the very next day, and they will have those exercise benefits because it does affect your hormones eventually. So physiotherapists can branch out from just orthopedics or neurology or pediatrics and combine quite a lot of things in order to help their patients is what I'm talking about right now. So we've used physiotherapy to improve joint space width. I don't know if it is very clear to you all. This is the medial joint space that is before and that is after. So um, there's no pointer here. But if you can see the medial joint space on the left and the medial joint space on the right, and this is just after a few sessions of dry needling to the muscles of the thigh and the leg and the buttocks as well. So I particularly specialize in biomechanics. My studies have been in biokinesiology. So when we work on understanding how the biomechanics of the knee joint or the joints above and below have changed, you will know which muscles to conduct acupuncture or to do dry needling on. And then eventually that itself helps improve the movement and the joint positioning, that eventually changes the joint space width. So this is not involving any joint mobilization or anything. This is just simple dry needling, and nothing has been done to the bone. Everything done to the muscles, fascia. That's it. This is patellofemoral joint space width, which is before and after. So if you can see, there's a lot of haziness in the muscle tissue above the patella as well. I don't have a pointer right here, but above the patella, if you can see the little white haziness of the muscles, even that changes post acupuncture. So literally the physiology of the muscle changes, and even though you don't really see muscle as much on an x-ray, you can still see how the muscle has changed with regards to the haziness below, even in the patella tendon. Everything changes. Which brings me back. You never needle a tendon, you never needle a nerve, you don't needle the diaphragm, no matter what any instructor is teaching you. And I need to bring this up, no matter what the consequences, because you have to understand that nerves do not tolerate acupuncture. So anybody who's doing neural needling, nerves have longitudinal and they have translational mobility. So whenever you bring anything sharp close to a nerve, the nerve is going to move away from it. So you're not going to be able to needle a nerve. You can needle muscles, you can needle ligaments, you can needle fascia. You cannot, you can even needle periosteum of bones. You cannot needle a nerve. You cannot and should not needle the diaphragm because it's too close to the pleura. It's dangerous. So there are certain structures you should never needle because they're dangerous, and there are certain structures you should never needle because it just doesn't make sense. So this is needling and the acupuncture of, or dry needling of the muscles in patellofemoral arthritis. Again, knee joint space increased in the medial joint space of another osteoarthritic patient. I don't know if you can visualize the patella in right around the femur. Even the patella tends to move on account of changing of the biomechanical element of all the muscles. This is a patient whose knee joint space was completely closed and he could not flex his knee, could not bend it at all. And just about 4 to 5 sessions of dry needling, we had a slight improvement in joint space width, which was used for the patient. He could flex his knee to a good 30-45 degrees within a few sessions. And that itself encouraged the patient to go more forwards with regards to doing more sessions and not going in for surgery. This is where we have diversified with acupuncture. We have gone into acupuncture to giving it to the scalp. So anybody who has had hair fall, hair loss, I would not say hair loss which is far too advanced. It does not work there. But somebody who is having telogen effluvium, somebody who has lost hair on account of hormones due to stress, somebody who's had hair graying as well. So I have some more pictures. This is, women tend to have a Christmas tree like appearance. When you take a mid partition, it's called female pattern hair balding or hair loss. So they tend to have a widening of the central gap. And as we conduct sessions for improving the scalp fascia and the movement of the scalp and how blood circulation improves to the scalp through acupuncture needling, you can see that the hairline sort of becomes marginally thinner, which is better, which shows us that hair volume has increased. So this is another male patient. I don't know if you all can see. This is another male patient. This patient here had a gallbladder issue. So here in physiotherapy, even though I'm sorry, I'm pulling away from dry needling here, this patient is a patient with a history of gallstones. Now, typically when you have a gallbladder issue, that is gallstones, the bile is blocked, your digestion is not that good, you tend to have a lot of acidity, you tend to have a lot of skin rashes. This patient also had a lot of hair graying along with hair fall, but almost 50%, I mean, he's still partway through his treatment, but 50% of his hair graying was reversed. And that was not just through acupuncture, we did that through nutrition as well. But the good part about applying nutrition to this patient was he did not have to remove his gallbladder, which is typically the line of treatment when you have gallstones. They want to avoid getting pancreatitis. They don't want an inflammation of your pancreas. And as a result of that, surgeons normally suggest the gallbladder to be removed. Now, when that happens, it eventually in the long term causes problems with the small intestine. But those things are not explained to the patient. And therefore, it is important to understand that the body has an excellent mechanism of healing. we just haven't gone that far yet in terms of finding out what can we do. Are we patient enough? Is the patient enough as well? So this patient here was suggested a nutrition program, and we also did some visceral rehab for his gallbladder, which is a mobilization of the organs. We did it for his gallbladder, his liver, and that itself improved his gallbladder. His gallstone size was decreased by almost half size. His prostate size decreased. So when we did all of that, his hair graying also reversed, and we did some acupuncture for the scalp as well. So it was a combination of techniques, not just one, but I thought it was an interesting case to bring out and show to you all. This was me actually. This was me some time back. That's my scalp. And I did some acupuncture to my scalp when I had a lot of hair fall, when I had chikungunya. So whenever your body goes through a very harsh problem or extreme stress, so if you've had, let's say, any kind of malaria, chikungunya, or surgery, if you've gone through pregnancy, anything that is very stressful for the body, if you've lost somebody dear, if you've had heartbreak, any of those things, anything that is too stressful for the mind or the body, all kinds of nutrition is taken away from the hair and it is given to all of the areas that require you to survive, to subsist, and therefore nutrition from the hair is deprived. That is as gross an oversimplification as I can give to you today, but literally hair nutrition is pulled out, and that is the reason why 2 to 3 months later, after a stressful event, you'll have a lot of hair fall, which we describe as telogen effluvium. Now, the point is, after the telogen effluvium, what do you do that will make the next growth of hair cycle, the hair growth cycle, be stronger? Because hair will regrow after that. But what do you do in order to make sure that hair will stay and not fall off again? That is important, especially after this phase of telogen effluvium. So, of course, you do make sure your nutrition is good as well. I did a lot of acupuncture for my scalp and certain points as well. This is a person that I was mentioning to with regards to hair graying. We did acupuncture for her as well, and we also did a nutrition program. So that helped her hair regrowth as well, and it helped the reversal of hair graying. Now, mind you, that hair graying we would not employ to somebody in their 60s, well into their 60s and 70s, when hair naturally turns gray due to the decrease in hormones. This is a younger person, about 25 to 30 years, and we can reverse hair graying in a person that is younger, not someone who is way older, when your hair naturally starts to gray. This is again the Christmas tree pattern that I was talking about in women. This is the loss of hair in women seen hormonally, which causes a Christmas tree appearance. We have started with a lot of acupuncture to facial muscles as well. There are over 50 muscles in the head and face and neck. So if your neck posture is good enough, if your cervical spine moves well, the jaw moves well, your scalp fascia is not adherent and it moves well, the facial muscles stay good. So we have also realized that there is a difference between strengthening your facial muscles and doing yoga for your facial muscles. Yoga, that is facial yoga, is a lot of stretching to the facial muscles, which is exactly the opposite of what you would do if you were to inject your face with Botox. Botox is all about shortening and paralyzing and making your facial muscles more stiffer. You want your facial muscles to be stronger and shorter in order to look younger. You don't want to stretch them. The reason being because the face does not have fascia. There's only one muscle which has a little amount of fascia, but all of your fascia stops in the scalp and the neck. So facial muscles have a different kind of mechanics as opposed to the remainder part of your body. You have fascia all over your body. You're gift wrapped with fascia everywhere, but not so much in the face. So the health of your facial muscles is equal to how younger you look on your face and how well your face looks, the appearance that is. So, which is why we have started with a lot of acupuncture for facial muscles as well, which has helped reverse crow's feet and fine lines. It has helped people with melasma as well. So there are simple techniques that can be learned if we just know the skill of dry needling, diversify from there, and use it on all muscles. This is just one of the pictures we have. I'm going to demonstrate a few things if I can have some candidates. So is anybody open to anything? Fantastic. Students will be welcome. So there are certain points that I like to employ, and these points come from Chinese acupuncture, which is again a different kind of acupuncture. I do dry needling, but I'm also licensed to practice Chinese acupuncture with the Maharashtra Acupuncture Council. I use both forms because I don't think we should limit ourselves to one thing when you can use different forms that have been evidence based, that have been proven to work. So why not use them on our patients? So there are different points. This is a GV20 and the EX point, which is wonderful. You use it right on your scalp. I don't mind anybody coming over, and I'll demonstrate a few points. I hope everybody is open for a little bit of practicals. Yes? Perfect. Thank you. Please put the mic for me. Put the mic for me. Hands up. You're on the lapel. Please go ahead, put it on the lapel. Thank you. My hands are sanitized, so I don't want to use it. Right. So in acupuncture, especially in Chinese acupuncture, there is a method of measurement called CUN. It's called Chun. And Chun is the distance of the IP joint of the patient's thumb. So if you have an idea of the patient's anthropometry, you can just take that distance there, and then you can decide where those points are located, because those points are fixed. The acupuncture points in Chinese acupuncture are fixed. So you know where those points are. They will only change with regards to the anthropometry of the patient. If a particular point is, let's say, on your olecranon unprocessed tip, it'll always be there on the olecranon unprocessed tip for all patients. But if it's, let's say, 1 chun above, then 1 chun will be the width of this IP joint of the thumb of that patient. So somebody might have a leaner IP joint, a width would be leaner, or somebody would have a broader one. And that would change the distance of where I would put the needle. Is that right? Did everybody understand that? All right. All right, you can lie down. Can you help me remove this, please? Just this. Thank you. Grab a chair for you, please. Thank you. Please lie down. And you can let us know if you're feeling a little sleepy, drowsy, head heavy, anything in some time, if it is something you feel. So, do you have a cold? Were you the person who put her hand up when you said you had a cold? What's your name? Siddhi, please sit. Both of you, please, could you both of you all get a chair? Thank you. So, this is a technique we have copyrighted actually, which is called a sinus acupuncture needling technique. There's no needling done for the sinus area. There are points in Chinese acupuncture related to the large intestine, the stomach, the urinary bladder. There are certain points around the eyes, around the nostrils, which help with colds. But I happened to accidentally discover this point when I was working at the clinic, and now we've copyrighted that. So we help a lot of patients put these needles right around the sinus. And I don't know if you can see it right there. These needles are little tiny, very tiny needles, which the patient can take home with them. And they have a little sticker that, it's a 1/2 mm needle, just stays on the surface of your skin. Now, what this does is it opens up the sinuses for a lot of people, so they are able to breathe better. And the moment they can breathe better, they just feel better. But then secondly, it also helps them drain their sinuses. I mean, everything starts coming out. So instead of the cold going downwards into the lower respiratory tract, or the throat irritation, which typically is the start of most colds, when my staff tends to get a little bit of throat irritation, we just immediately put it, and then the throat irritation is gone. There's no cold left afterwards. So the whole process of the common cold is stopped right in its steps just by doing an acupuncture to the sinuses, because your sinuses are literally the first line of defense, and then your tonsils. So if your sinuses can literally drain effectively, can open up, a lot of things can change with regards to getting a common cold or shortening the duration of a common cold if your common cold is advanced. Don't move your feet, okay? I've just kept a needle next to your feet, so don't move it. Thank you. Close your eyes, please. Just want to clean the area. Close your eyes. Don't open them, because the spirit, and it will go into your eyes. Close your eyes, please. Don't open your eyes. So I don't know if you all can zoom in quite close enough here, but it's a very tiny, teeny tiny needle, which I'm sure you all can't see from there, but that's just about 1/2 mm of it. And don't open your eyes yet. I'm going to put it right there. Next to the opening of her sinuses, and not sharp enough when I touch, when I palpate that, when I press it, nothing's sharp, right? Okay. So you can open your eyes now yourself. Thank you. So you can let me know in a few minutes if you feel your nostril has opened up, if it has worked. There's always people in whom sometimes it may not work. I've seen a very small percentage of people in whom it does drain the nose, but their nostrils are still blocked because they have polyps and they have other complications also. So if they have no other things, typically the nose tends to drain. I'm going to put for you, madam. All right. This is not sharp, right? All right, you can open your eyes. So we have been doing this we did this during COVID, during the entire period of COVID, and we've been doing it for many years right now. There's obviously a lot of data, but it's not published yet because it's just a very small point, that's it. But yeah, you all can let me know in some time about how you all feel. You all can just open your eyes, just sit for some time. Thank you. So I'll move on with the presentation and then possibly you can just close your eyes and relax. I know it's difficult to sleep with your eyes closed in public with all the lights and the stage lights here, but try if you can. Just close your eyes. All right, so can I have my presentation back on? So we were talking about the GV20 and the EX points, and those are the list of things that happen if you use the GVEX points in your patients. You can actually treat them with, especially with regards to feeling a lot more relaxed and sleepy. SP6 and the SP10 points. Now, I don't know if you all have realized this anytime. When you all have viral fevers or when you all fall really ill, have any one of you all felt pain around your knees, around here, or maybe around your thumbs? You feel a little bit of stiffness or pain around your thumbs. So those are the points. The SP6 point is actually right down in your feet, but the SP10 point is the one around your VMO. It's just close around your VMO. It's around 2 chun above the medial pole of your patella. So that is one point. In Chinese acupuncture, they talk about this point being an antibiotic point. So if you can just use a needle to stimulate it, it can actually help improve how that particular meridian functions. And it actually does help because it removes all of that heavy pain, that stiffness around the knee joint as well. So if any one of y'all have felt it, y'all would know what I mean. You feel a little bit of knee heaviness and stiffness. So typically you see it in viral disorders. You'll see that. When I had chikungunya, I literally felt my thumbs extremely heavy and painful for no particular reason. I do a lot of manual work and a lot of manual therapy. My thumbs don't tend to hurt that much, ever. But the viral disease took a lot from my joints. And that's when I realized there's another point here which I'll come up with. It's called LI4. So there's a point here, large intestine 4, which actually helps. And if you stimulate that point, it actually helps your joints. It helps a lot of systems in the body, your immune system in particular. This is another point. Now, this point is old and it has been used by a lot of people. There's a point in between your tibia and fibula. It's called the ST36 point, which if you just massage, even as an athlete, even as a person who's walking a lot, people who tend to have a lot of leg heaviness at the end of the day due to standing excessively. This point is called the 3-mile point, and we've seen also, and I have not really accepted something just because Chinese acupuncture has said so. I've actually done it on several patients. I've done it on myself. And it has opened my eyes to understanding that, we could possibly look at different therapies to be used for our own benefit as well. So this point has helped with regards to removing tiredness in the legs, with regards to removing pain in the legs. So it's a point between your tibial tuberosity and the fibula head, right midway in between. You can just massage a point there, and even if you just manually acupressure that point, that tends to help you not feel tired in your feet, and you can walk 3 miles longer. And that's the reason why it's called the 3-mile point. You can actually go on for longer walking, running, whatever it is you have to do. This point here is on the tibialis anterior muscle. It's pretty much on the anterior portion right here. And it's 8 chun below your tibial tuberosity. So if you take 8 thumb, if you take your 8 thumb distances below from the tibial tuberosity. There's a painful point right midway between the tibialis anterior muscle. You all can try it on yourself. If anybody has shoulder pain in particular, does anybody have shoulder pain? Please come in. I don't think any younger students, please come in if you've raised your hand. Don't hesitate. Just come in. Just run, please, because we can't extend the presentation. Come on. So if I don't think any younger person will have shoulder arthritis right now, but if anybody has that, I can at least show you where to look for it. So if you can just manually even massage it, even if you don't know acupuncture, manually massaging that point itself reduces some amount of shoulder stiffness, improves some amount of shoulder range for patients. So definitely use it in your practice. Grab a chair for yourself, please. So it can actually improve your practice with just knowing certain points and how they can work for you. Please come here. I'll just have them speak. Tell me what you feel in your nose.
It is much better. It is
What is much?
nostrils. It is open also. Yeah.
That's what it helps with regards to opening up your, your breathing a little better. Now you might start leaking also. And if that happens, that is completely understandable, okay? But don't remove it for 3 to 5 days. If you can, keep it on. It'll be good. I know you may not be able to attend a public function and everybody's going to ask questioning you. You can just tell them it's for your spectacles or something. But you just have to understand that. Sorry? You can wear your specs on top of that. It's completely okay. The only thing is, remember that if you're going to wash your face, don't rub it hard because this needle is just about half mm. If you're going to rub it hard, it's going to move and then it'll start to prick. And keep it for as long as you can. 3 to 5 days is what we typically recommend. But if you wash, don't rub it. You can just put soap everywhere and water, dab your face with a towel, don't rub it. And when you're removing it, just remove it like a band-aid. Press the needle down with maybe a spoon or a stone and throw it in the dustbin. Okay? I'll explain later. All right? So with regards to you, madam, we'll go with your ST36 point. So this is right in the middle. Can you go there, please? Thank you. I'll help you. Thank you. We'll do that later. You can come and sit down. You keep the chairs back. Thank you. So, pretty much, that's okay. Then we'll go for the right side. So if it's the right shoulder, I would go for the right side. I'm sorry. So you find the tibial tuberosity. You go around 8 chun. And patient's thumb, not my thumb. So I have an idea of how big or broad her IP joint is. So I'm going to go with that. Can you hold this for me? Thank you. I find her tibial tuberosity and I go 1, 2, 3, 4, 5, 6, 7, 8. Go on the tibialis anterior muscle and there. Any pain there? So I'm pressing you here. So see this? I'm pressing you here on your hand. You understand what pressure this is? Is this pressure or is this pain? And this is pressure or pain. Okay. So this point here, the ST38 point, on your body, use your IP joint distance of the thumb and go 8 steps down from the tibial tuberosity. Stay on the tibialis anterior muscle and you'll find that point. In case you are a little up and down, you might just go a little up and down, go a few millimeters up and down, and you'll definitely find that point if you have shoulder dysfunction. So typically we have seen if somebody can't acupuncture, we normally tell the patient you can just massage it. It doesn't matter about the direction of massage, but just massage it kind of, obviously don't bruise it, but massage it on a daily basis. Nothing with regards to how long to massage. Go ahead and massage as and when you remember it. So that is the ST38 point. Can I take that? Thank you, madam. Okay. The LI4 point is the point between your thumb and your index finger. So if you take your IP joint again, and if you take your own IP joint, put it on your web space here. So this little crease here of your IP joint, put it on your web space. Can you all, everybody, can you all do it? Can you practice? I don't want you all just staring into the dark and onto your phones, please. You'll have come here, please listen. Take your IP joint here, put it into your web space, and then bend your thumb so that the tip of your thumb is where I put in a needle. So that is where you put in the needle. That's the LI4 point. If anybody wants to try that out, I'll do it quickly for you all as well. Please come and run and come in if somebody wants to come in. Don't wait. Anybody, please, just run and come in if they want to. So this LI4 point is another immune system point. If you cannot needle, if you don't want to needle, you all can even massage that point. And it tends to be very painful in people who have immunity that is not so good. I would not really say poor immunity, but if their immune system is inflamed, if you have a lot of inflammation in their body, this point tends to be painful. Putting a simple needle itself will twitch, and that's the adductor pollicis muscle. But when you needle that as well, it does help stimulate that point as well. So you're actually getting a crossover of Chinese acupuncture and dry needling, wherein actually a lot of points in Chinese acupuncture and dry needling tend to overlap. This is another point called the K3 kidney point, which is near your medial malleolus, which is sort of overlapping with your tibialis posterior muscle. And your tibialis posterior muscle literally controls the movement of your foot. It's attached to 9 bones of your foot. It has 9 attachments, in fact, I would put it that way. It has 9 attachments and it literally moves your tibia and fibula. It's between the tibia fibula, the interosseous membrane, and the tibialis posterior. They both move. How your knee joint shapes after that is based on your tibialis posterior muscle. So it also, your foot mechanics is shaped with your, it's dependent on your tibialis posterior muscle. So we do tend to take this point into consideration. It does not change the tibialis posterior function as such, but it does stimulate a little bit of it at least. This is a sinus acupuncture, which I had 2 candidates here, and that is what we did. This is again another few things with regards to knee joint space width. If you can see the medial joint space, it's a tiny little improvement in medial joint space, but it's enough for the patient because the patient is able to bend. But this is just the initial x-rays. We have a lot more x-rays, and then as we moved ahead, it did improve the knee joint space width. However, we have not gone forward with checking with MRIs whether the knee joint space width actually improved the health of the cartilage. We have yet to see that because that is expensive for the patient, and to go through all of that for the patient was a little difficult. So we're looking for funding, and then we can hope to get certain MRIs done to see how knee joint space width has influenced cartilage health and reversed cartilage health. Because all of the osteoarthritic research out there is all about improving cartilage health. But without improvement in joint space width, I don't see how we can improve cartilage health. This is another thing I think a lot of been told about trigger finger and trigger thumb, and there's actually no known treatment. We tend to ultrasound it or we do a little bit of MFR. We put a little needle into the tenosynovium and we just do it once or twice and it's gone. The trigger finger is gone. So literally this was another thing we actually discovered by accident. We just asked the patient's consent. The patient was okay with it. We needled it, and in a couple of sessions it was just gone. So there's no real treatment as such for trigger finger, but we just saw that it could work, and then now people who have that get better without any other form of treatment like steroids or anything.
Madam,
Yeah, we're done, sir. This is the last part. So I always enforce and I always emphasize that it is possible to do that, but a little talk can go a long way for a patient who is healing or is not doing very well. And yes, I would advise everybody to learn a lot more about the human body and not restrict themselves to any one thing. Just a mode of caution is whenever it comes to just learning from workshops, whenever we come out of workshops, please go and read the original author who has written the book. What books can tell you and what practice can tell you, a 2-day workshop cannot tell you. That is all that I would like to tell everybody else. So thank you so much for listening to me today. And I hope there's been a small takeaway or something that I could contribute to the knowledge you're about to gain in this conference. Thank you again. Have a good day.
Thank you.
I'm sorry, we
I
forgot one
request the
person here.
chairperson
I'm so sorry, ma'am.
to present a
Forgot you.
token of
Can you please sit down?
appreciation to Ms. Diana Pinto.
Yeah. Can you tell us how you're doing? Are you feeling okay?
I'm good.
Yeah. Are you feeling a little relaxed?
Yes.
Feeling good, that's okay. But are you feeling relaxed? Are you feeling a little drowsy?
A little bit drowsy and sleepy.
So it tends to make the person feel a little drowsy. You want to just sort of just relax. Give me a moment. I'm going to remove your needles. I'm done, madam. Thank you.
Thank you.
I'll remove those for you. You might catch some radio signals otherwise. Just get those there. Thank you. Look down. All right. All done. Thank you. I'm going to keep these needles here, so I don't know if you'll have any biomedical waste
You
disposal.
can
So I'm
keep
just
that.
going to keep it here.
Wind it up.
Thank you. Thank you. Thank you for volunteering. Thanks.
I request the chairpersons to present the token of appreciation.
I'm going to leave this here, sir. Madam, I'll leave this here. Thanks. Thank you so much, sir. Thank you. Dr. Prashant.
I request Dr. Vinuta Deshpande. Dr. Vinuta Deshpande. Please present a moment of appreciation to our chairpersons. Thank you, Dr. Ravi. Thank you, Dr. Prashant. We all request you to stay back. We have the inauguration starting in next 5 minutes. Do we have the video of the sponsors, Vijay sir? You can play that video. I request the delegates to take their seats as the guests have already arrived. Delegates, please settle down. I request everybody to please be seated as the Chairman Kelly Society has already arrived outside.
check this, check. Check, hello, this, check. Hello, check, hello, this, check. Check, hello,
Delegates, please be seated. Delegates, a kind request, please
check,
be
hello,
seated.
this, check. Check, hello, this. Hello, check, hello, this, check.
I request all the delegates to please take their seats. Delegates, please clear the way on the left side. Delegates, please clear the way on the left side where the guests would be entering the auditorium. Dr. Dhaval, please clear this way for the guests to enter, and the delegates can be requested to enter from the other gate. The delegates are entering the auditorium. A very warm and dignified welcome to each one of you, distinguished academicians, pioneering researchers, respected guests, and delegates from across India and abroad. On behalf of the organizing committee, it is my profound privilege to welcome you to Pearl Physiocon 2025, the international conference, a premier global platform dedicated to advancing science, practice, research, and interdisciplinary collaboration in physiotherapy. This year's conference holds exceptionally significant as it coincides with a remarkable milestone, the completion of 30 glorious years of excellence of Cayley Institute of Physiotherapy. The theme for Pearl Physiocon 2025, that is shaping the future, technology-driven patient care, reflects a collective commitment to embracing emerging technologies, digital health paradigms, and evidence-informed innovations that redefine rehabilitation and patient outcomes. With participation from distinguished national and international experts, this conference aims to bridge cutting edge scientific knowledge with advanced clinical practice, empowering practitioners, researchers, and students alike. So, as a symbol of Karnataka's heritage and to reflect dignity, respect, and culture, our guests have worn Mysore Petha and Shalya. We request all the dignitaries to come on the days. I request the organizing committee members to escort the dignitaries on the days. I request Dr. Sanjeev Kumar sir, Dr. Deepa Metkud.
To invoke the sense of harmony and auspiciousness, we now invite the accomplished staff and student of Cayley School of Music to present the inaugural song. May the serenity of their rendition set the perfect tone for the day.
Hello.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा विश्वविनोदय विद्याचेतन सर्वहृदय संस्कारी सर्वहृदय संस्कारी जय भारती करुणाड सरस्वती गुरि गोकुल सुर शिल्प कलाकृति जय भारती करुणाड सरस्वती गुरि गोकुल सुर शिल्प कलाकृति कृष्णे तुंगे कावेरी पवित्रिका क्षेत्र मनोहारी क्षेत्र मनोहारी विश्वविनोदन विद्याचेतन सर्वहृदय संस्कारी सर्वहृदय संस्कारी ಸಪ್ತರ್ಷಿಗಳಾಂತರ್ಯದ ಕನಸಿಗೆ ಶಿಕ್ಷಣ ದಾಸೋಹದ ಹೊಂದೀವಿ ನಾಡಗಡಿಯೊಳಗೆ ನವಾರುಣೋದಯ ಕಲರವರೋ ಮಾಂಚನಕಾರಿ ಉನ್ನತ ವಿದ್ಯಾಲಂಕಿತ ಗಿರಿಗಳ ಬೀರಿ ಹೊಳೆವ ನಕ್ಷತ್ರದ ಗುರಿಗಳ ಸಾಧನ ಬೋಧನ ಶೋಧನ ಬದುಕಿದು ಚಿರಂತನವು ಶುಭಕಾರಿ ಚಿರಂತನವು ಶುಭಕಾರಿ ವಿಶ್ವವಿನೋದನ ವಿದ್ಯಾಚೇತನ ಸರ್ವಹೃದಯ ಸಂಸ್ಕಾರಿ ಸರ್ವಹೃದಯ ಸಂಸ್ಕಾರಿ ತ್ಯಾಗ ಭೋಗ ಸಮಯೋಗದ ದೃಷ್ಟಿ ಬೆಳವಲ ಮಲಕರ ಸುಂದರ ಸೃಷ್ಟಿ ಜ್ಞಾನದ ವಿಜ್ಞಾನದ ಕಲೆ ಐಸಿರಿ ಸಾರೋದಯ ಧಾರಾನಗರಿ ಅರಿವೇ ಗುರು ನುಡಿ ಜ್ಯೋತಿರ್ಲಿಂಗ ಅರಿವೇ ಗುರು ನುಡಿ ಜ್ಯೋತಿರ್ಲಿಂಗ ದಯವೇ ಧರ್ಮದ ಮೂಲ ತರಂಗ ವಿಶ್ವ ಭಾರತಿಗೆ ಕನ್ನಡ ದಾರುತಿ ಮೊಳಗಲಿ ಮಂಗಳ ಜಯವೇರಿ ಮೊಳಗಲಿ ಮಂಗಳ ಜಯವೇರಿ ಮೊಳಗಲಿ ಮಂಗಳ ಜಯವೇರಿ ಮೊಳಗಲಿ ಮಂಗಳ ಜಯವೇರಿ ಮೊಳಗಲಿ ಮಂಗಳ ಜಯವೇರಿ.
Thank you for that soulful performance. We now proceed to the traditional and symbolic lighting of the lamp, representing wisdom, enlightenment, and pursuit of knowledge. I request all the dignitaries on the dais to kindly join in for this sacred moment.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिः परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीप नमोऽस्तु ते। शाधि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठे गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम्
To extend a formal welcome and share the vision behind this conference, I request Dr. Santosh Metkud sir to organizing chair deliver a welcome address.
Good morning, respected dignitaries, distinguished guests, senior members of physiotherapy fraternity, esteemed faculty, dear students, and delegates. It's indeed a moment of great pride, honor, and joy as we gather here today for the inaugural ceremony of Pearl Physiocon 2025. This year is particularly special as the KLE Institute of Physiotherapy proudly celebrates 30 glorious years of unwavering commitment to excellence in education, research, and clinical service. A journey of 1,000 miles begins with a single step, and 3 decades ago, KLE Institute of Physiotherapy embarked on a journey of fueled by vision, dedication, and a steadfast belief in empowering the healthcare community. Today, as we stand at this remarkable milestone, we reflect not only upon the years that have passed, upon the lives transformed and the knowledge created and the legacy built. Over the 30 years, our institute has grown into a beacon of learning, innovation, compassionate care. We have nurtured generations of physiotherapists who continue to contribute meaningfully across India and beyond. This celebration is not just about time, it is about the relentless pursuit of excellence that denies the very spirit of KLE. It gives me immense pleasure to extend a warm and heartfelt welcome to each one of you to Pearl Physiocon 2025, organized under the esteemed banner of KLE Academy of Higher Education and Research, Belagavi. At the outset, it is our honor to welcome the president of today's function, Dr. Prabhakar Kore sir, Honorable Chancellor of KAIR, Chairman of KLE Society, and the former member of Rajya Sabha. Sir, your visionary leadership, philanthropic spirit, and a lifelong commitment to education and healthcare continue to inspire all of us. Your presence here today is a profound encouragement. We are equally delighted to welcome Dr. Vishwanath Patanchetti, sir, Registrar of Kahir University. Sir, your constant support, guidance, and encouragement have strengthened our academic and research endeavors, motivating us to reach new benchmarks. A very special and a heartfelt welcome to our chief guest, Dr. Diana Edulji, former captain of Indian women's cricket team. Madam, your extraordinary journey, marked by discipline, resilience, and exceptional leadership, embodies the essence of the perseverance. Success, as you exemplify, is not the final. Failure is not fatal. It is the courage to continue that counts. Your presence truly enriches this event. We are honored to welcome our guest of honors, Dr. Ali Irani, Dr. Ketan Patikar, the eminent personalities in physiotherapy and sports medicine. Your contribution to the profession have paved the way for innovation, excellence, and global recognition. We are grateful for your continuous guidance and mentorship. We also extend a warm welcome to Dr. VP Gupta and Dr. Ashish Kakkar, distinguished academician whose expertise has immensely shaped the evolution of physiotherapy education and clinical practice in our country. To all our respected senior academicians, mentors, clinicians, and representatives from various institutes across India, we extend our deepest appreciation. Your presence today is inspiration to every young mind seated here. A very special acknowledgement goes to the dedicated organizing committee of Pearl Physiocon, Dr. Sanjeev Kumar sir, Dr. Vijay Kage, Dr. Ganesh VR, and Dr. Deepa Medgud. Your meticulous planning, tireless efforts, and unwavering commitment have made this conference a reality. I welcome you all. As, as John Wooden said, success comes from knowing that you did your best to become the best you are capable of becoming. The team has truly embodied this. I extend my Sincere welcome to the speakers, the panelists, the delegates, faculty, students, and participants who have joined us from near and far. Your enthusiasm, curiosity, and dedication make this academic gathering a meaningful and impactful. As we commence the celebration of knowledge, collaboration, and innovation, let us embrace the opportunity to learn, share, and grow. Thank you. Happy learning.
Thank you, sir. As a gesture of our deepest appreciation, we now present mementos and bouquets to our esteemed dignitaries, honoring their valuable presence and support in elevating this conference. We now request Dr. Sanjeev Kumar sir to present a bouquet to our esteemed chief guest, Mrs. Dinah Edilji ma'am. I request sir to give a token of our appreciation to our beloved chairman, Dr. Prabhakar Kore sir. I invite Dr. Vinuta to present a bouquet to our distinguished guest of honor, Dr. Ali Irani sir.
I request Dr. Aarti Welling to present a bouquet to our esteemed guest, Dr. V.P. Gupta sir. And to Dr. Ashish Kakkad sir.
I request Dr. Vasudha to present a bouquet to our registrar, Dr. V.M. Pattan Shetty sir. To Dr. Ketan Batekar sir.
I request Dr. Dhaval to present a bouquet to our principal, Dr. Sanjeev Kumar sir. Dr. Vijay Kage sir, Professor and Dean Faculty of Physiotherapy and member of National Commission for Allied and Healthcare Professionals. Professor and Vice Principal, Dr. Santosh Medkud. Professor and Head of the Department of CVTS Physiotherapy, Dr. Ganesh. And Professor and Head Todi of Pediatric Physiotherapy, Dr. Deepa Medkud.
We are pleased to present the souvenir of Pearl Physiocon 2025, a compilation of conference key highlights, messages, and contributions. This publication reflects the spirit of achievements of the event. We now invite all our dignitaries to formally release the souvenir.
Thank you, sirs. We now present two prestigious awards to honor the individuals whose foresight, innovation, and inspiring leadership have created a remarkable impact. Their work has truly guided our profession towards a brighter, progressive future. The first award is Visionary Leadership Award, and it is presented to Dr. Deepak Kumar, sir. I request sir to come on the dais. I request our chief guest and other dignitaries to join to felicitate sir. The next award is Exceptional Service Award and is presented to Dr. Akhauri Gaurang Kumar Sinha. Sir, I request you to please come on the dais. Thank you, sirs. It's a privilege to introduce our esteemed chief guest, Mrs. Dinah Edulji, one of the most iconic and pioneering figures in Indian sports. Born on 26 January 1956 in Mumbai, Mrs. Edulji displayed an extraordinary passion for sports from a very young age. Before making her mark in cricket, she excelled in basketball and table tennis at the junior national level. Her journey in cricket began in the railway colony where she grew up, and her skills were further shaped under the guidance of the legendary Mr. Lala Amarnath at a special cricket camp. A trailblazer in every sense, Mrs. Edulji went on to represent railways and then the Indian national women's cricket team, emerging as one of the most successful slow left arm orthodox bowlers in history of the sports. She made her international debut in 1975, and by 1978 she was a leading Indian cricket team captain. She remains India's highest wicket taker in women's test cricket and third highest globally, with an outstanding career that includes around 5,000 deliveries in test matches, more than any women cricketer in the history. Known not only for her cricketing brilliance, but also for her fearless personality, Mrs. Sedulji famously challenged the discriminatory traditions when she was refused entry to the Lord's Pavilion, boldly calling for change and equality in sports. Throughout her career, she claimed 120 international wickets, the highest at her time of retirement. Her remarkable contributions have been widely honored. Mrs. Sedulji received the prestigious Arjuna Award in 1983 and Padma Shri Award in 2002. She was the first Indian women cricketer to be granted a benefit match and has continued to shape the sport through leadership roles, including her historic appointment to the BCCI administration panel by the Supreme Court of India and by becoming the first woman on the BCCI selection panel. In 2023, she achieved one of the highest global honors in cricket, her induction to the ICC Cricket Hall of Fame. Today, we are deeply honored to have with us a legendary sportsperson, a fearless advocate for women in sports, and an inspiration to generation, Mrs. Dinah Edulji. Ma'am, we humbly request you to grace the occasion with your inspiring words of wisdom.
Good afternoon, everybody. This is a very strange chief guest I've become because I've never seen so many physiotherapists and this thing all over, left, right, center, front, behind. It is very difficult because in the time I started playing, there was no physiotherapy. Physiotherapy has moved along, and physiotherapy in sports is needed very badly these days. And now the importance of physiotherapy is so much that we have a physiotherapist connected with every team that is playing national or international, all age groups, right from under 14 to the seniors, as well as the international players. Without that, it is not going to be possible. So physiotherapy definitely is a career to look forward to. There's ample scope, there's equality. Men and women both are treated at par, in at least in the field of cricket. Today, we have 15 players, but we have a battery of about 15 to 20 people behind the scenes working to keep the players fit. And the physiotherapy job is absolutely, I would say, it's very difficult because they have to be constantly trying to get the player back onto the ground, whether it's morning, evening, night, maybe even middle of the night. Like you just saw Shubham Gill woke up with a stiff neck and the physios had to work on him right through, but it had to come to a stage where he had to be taken to the hospital. But the work done on him as he's back now on his feet, and that is the role of a physiotherapist. I know how it was in our days. It was very difficult. I started in the late 70s, but in the late 80s, I know who the person who made me fit and really made me struggle was Dr. Ali Irani. I used to go to his clinic, and I also have another person here, Dr. Ijaz Eshai, who has also treated me, got me fit completely so that I could stretch my career a little bit more. Thank you very much for having me here. I've come to Belgaum for the first time. It's a beautiful city. The weather is excellent. And I'm looking forward to this show. Thank you very much. God bless.
We are graced with the presence of our beloved chairman, Dr. Prabhakar Kore, sir. The leadership as chairman of the KLE Society since 84 and as a chancellor of KLE University. Your presence add immense value to this event, sir. We invite you to deliver the address.
Sorry, I supposed to speak last, but I was not well. Somehow I wanted to meet all these people here, so I came here. Namaskara to everybody. Today, chief guest of this function, Mrs. Diana, the ex-captain of Indian women cricket team, the Arjun Awardee and Padma Shri Awardee. Dr. Ali Irani, very, very close, I think. Every time he will in Belgaum, whenever we call him, I think last 30 years, he is working with us. In fact, he is a part of KLE. I will. Dr. VP Gupta, Ashish Kakkad, Ketan Bhatkar, rest of KLE University, Mr. M. Patan Shetty, principal of the KLE Physiotherapy College, distinguished guests, delegates, and friends. I welcome you. This city is a beautiful city and beautiful climate. KLE, almost we have completed 110 years now. It started in 1916, a great 7 teachers. And today, we are running almost 318 colleges throughout Karnataka, Maharashtra, Delhi. Almost 148,000 students studying in whole my institution. Almost all faculty we have. We have kindergarten to post-graduation in almost all faculty, including agriculture college. This society is established 7 great teachers. It's not belongs to any family nor any. It's a totally democratic setup. And where every 5 years we have a big election, and in the general body they elect the 12 people. Then there are 3 teachers from teacher community, totally 15 board members. Out of them, they select the chairman. So I think this is the only institution in India where you find a democratic and charitable institution. We have a lot of donors are there. Even today, the many donors, they come forward to give a whole property to this society because education plus health. We started first hospital in 1995-96. And today we are running almost more than 4,500 bedded hospital, including satellite hospital. We have almost all faculty. We can, in such a small place, we have a heart transplant, liver transplant, kidney transplant, lung transplant. And recently we opened a 300-bed cancer hospital in January under the President of India opened this hospital. Coming back to physiotherapy, I think we have 30 years back, nobody knows what is the physiotherapy. Mr. Ani know that. And we are the first people started a physiotherapy in Karnataka, this part of Karnataka. And even I think Bangalore was not there. And that this college, I think you can see the college also, what type of quality we are giving in educating this physiotherapy. We have one more college, physiotherapy in Hubli. There we are this December, we are inaugurating 1,000-bed hospital in Hubli, one medical school. So that is a 3rd medical college run by this society, sir. Of course, my friend just now I met, he is from Goa. He just missed the few vote from, next time I'll hope he will be MLA. So next time when he will be MLA, I'll start physiotherapy in Goa also. That was the only state. So I don't have to take much time, sir. I'm really very happy. Physiotherapy become is a very important part of this healthcare. Of course, Ali knows that when I was a Rajya Sabha member, there was no council, and I was health committee member in parliament. He came so many times, we fought, we met so many people. Almost last 20 years we are fighting for the council, and today that dream comes true. That council is here, and I have met many council members also. Only I request now council has taken place. The quality of colleges, what growing like a mushroom. So you must control the quality. I don't against the starting anybody college, but there is no hospital. How they can train the practical training? So these all problems here in India. I think Karnataka has the largest colleges, more than 110 colleges. And everybody competing each state. Here 110, let Andhra 150, let Maharashtra 120. So the council will surely look after the now quality. That's more important, sir. And once again, I welcome all the delegates. Your today and tomorrow, your 2 days. So stay comfortable, stay. Enjoy Northern Karnataka food. That's very famous food. You will really enjoy. And thank you, sir, calling me as one of the guests. Thank you. Thank you very much.
Thank you very much, sir, for the words of wisdom.
Next, we have a guest.
Namaste and very good morning. Esteemed invited guest on the dais,
Dr. Yajna Anmesh Shukla, a distinguished stalwart in the realm of healthcare, is a symbol of wisdom, grace, and visionary leadership. As an esteemed chairperson of a National Commission for Allied and Healthcare Professionals, NCAHP, Ministry of Health and Family Welfare, New Delhi, she stands as a trailblazer, empowering the physiotherapy fraternity with a dignity, policy, reform, and a national identity. A true architect of progress, she embodies intellect, integrity, and an unwavering commitment to elevating the standards of allied health professionals across India. With that brief introduction, we request to play the video of Dr. Yajna Anmesh Shukla, ma'am.
Namaste and very good morning. Esteemed invited guest on the dais, Dr. Prabhakar Kore sir, Honorable Vice Chancellor KLE, Dr. Vishwanath Patan Shetty sir, Registrar, Dr. Diana Edelji Madam, Dr. Ali Rani sir, Dr. Itika sir, Dr. VP Gupta sir, Dr. Ashish Kakkar, the entire organizing team of Pearl Physiocon, esteemed invited speakers, and my dear participants. Please accept my sincere apology for not being there physically due to prior commitments. I am delighted to know that KLE Academy of Higher Education and Research, Institute of Physiotherapy has organized an international conference, Pearl Physiocon, with a very appropriate theme of shaping the future technology-driven patient care. Many congratulations to the organizers. By bringing together clinicians, academicians, researchers, and innovators on one platform, it will catalyst the meaningful exchange of knowledge, expertise, and experience. And I humbly request all the participants to take full advantage of the expertised speakers. I also want to convey a message to young professionals that dream boldly, practice ethically, and lead courageously. India needs you not only as a clinician, but as an innovators, as a researchers, as a educators, and as a change makers. Please remember, when the physiotherapist is being given empowerment, then the empower is given for recovery, dignity, and human potentials. Many, many congratulations to Dr. Sanjeev Kumar, Dr. Vijay Kage, Dr. Santosh Mudgal, Dr. Ganesh Biar, and Dr. Deepa Mudgal and entire team of KLE for organizing such a mega event and thereby spreading the knowledge and expertise in the field of physiotherapy. I would also like to thank the organizer for giving me this opportunity to address you all. Thank you very much.
We are honored to introduce our guest of honor, Professor Dr. Ali Rani, one of India's most distinguished physiotherapists. He holds multiple advanced qualifications, including a PhD in sports medicine, PhD in anatomy of body movement and dance, and a Doctor of Physiotherapy from NUMS Spain. He currently serves as the head of the Department of Sports Medicine and Rehabilitation at Nanavati Max Super Specialty Hospital, Mumbai, and is a member of the Physiotherapy Professional Council, National Commission for Allied and Healthcare Professionals, Government of India. He is also the chairperson for international affairs of the IAP and principal at NMIMS University. With an illustrious career spanning decades, Dr. Irani is best known for his 10-year tenure as a physiotherapist of the Indian cricket team. He has been deeply involved in academics, research, disaster management training, community rehabilitation, and has served as a PhD guide and examiner at several universities in India and abroad. A highly decorated professional, Dr. Irani has received numerous honors, including the Hitra Oration Award, the Lifetime Achievement Award from IIP, fellowships from both Indian Association of Sports Medicine and IIP, and the Best Physiotherapist Award in India. He is an influencer, educator, an active member of several national and international physiotherapy bodies, and a respected voice in sports medicine and rehabilitation. With deep respect, sir, we invite you to take the stage and share your wisdom with us.
Respected Prabhakar Kore sir, Registrar, Pan Idolji, Chief Guest for today, Vijay sir, Sanjeev sir, my members at the Central Council, Gupta sir, Ashish, my Deepa ma'am, and all the seniors. My congratulations to Deepak and Sinha sir. Great work. Many more honors to come to you all. And lastly, my friend sitting here, Ketan Batikar. So thank you for the lovely work I've been reading in Goa. He has distributed more than 10,000 spectacles for people who could not see, and almost more than 100 cataract surgeries. Your Ketan Batikar Trust, Charitable Trust, is doing a great job. I hope you all take a leave from your work, and we all sitting here wish you the next election. We want a physiotherapist to be a MLA from Goa. Thank you all the foreign delegates who are here from Saudi Arabia and other countries sitting here. Welcome to India. I hope you all enjoy the next 2 days, and we want to listen to you all also, and happy learning to all the students sitting here. As we are gathered here today, KLE is a university that has first batch of 5 years physiotherapy course. All the best, Sanjeev sir, Vijay sir. And definitely it proves that from a 2 years diploma course, physiotherapy we came to 3.5, then 4.5, and cross all the hurdles to be a 5-year course. And as per government, we will be officially labeling ourselves as doctor from this year onwards. And no doubt, this year was an option of 4.5 and 5 years. Still, KLE took the courage to straight go for the 5-year course, and I wish them all the best. I hope the students know that my only coming to KLE, I cannot refuse Koresab is one thing. I remember when we were running up and down the parliament to ask for our council. So there was a joint commission made, joint parliamentary commission made to sort out our problem about the council. I think so. Dr. Deepak Kumar was with us. Dr. Gupta was with us. And we were so uncomfortable, lost in the parliament, nothing what to do. And came Dr. Prabhakar Kore. He made us so comfortable. He made us sit, he had a cup of tea with us, explained us how to go about with it. And with all his sources, the time he was a sitting Rajya Sabha member, he did his best. And I think so the stepping stone for the council started from there, where all the council members, many parliamentarians supported us. And it was his good books that he met everybody individually and spoke to the health minister. It is important that physiotherapy should have their own council. And today, I really wanted to thank him in presence, but please give my words. The way he has helped us, he has to be honored. And we are thankful that he did his best. And today we are having a council, independent council. So most of my friends sitting here, Dr. Gupta, Dr. Ashish, Dr. Vijay, we are all members of the central, but we are missing Iftikhar Ali, who is Karnataka state chairman for all the allied science. And he has asked to tell his apologies to the committee which has held the conference. Last moment he had to fly out of the country, but he said he will compensate. He'll only come to KLE to meet you all and definitely take long way. Dr. Palekar, sir, I heard that you have taken the highest number of students this year and wishing you all the best. It says that how much our physiotherapy is going ahead. And definitely the competition is between DY Patil Mumbai and DY Patil Pimpri. And let's hope you'll remain the same and nobody goes ahead of each other. Dr. Mishra, sir, thank you for coming. All my other friends sitting here, Ajal all great meeting all of you all here. And I'm sure the next 2 days will be a learning period for all of us. And all the state councils will be in charge of the states. Only if something arises, it will go to the central level. So I think so up to 100 seats, it was at the state level. You don't have to bother about the center. But all your membership, you have to become a member from where you have studied. So once you have got your membership, the part of it will be at the center. There will be a record at the central also. You'll be able to practice anywhere in the country. And a syllabus will be same, one syllabus, whole country. So that will make things easier. And even transfers will become easier because the syllabus will be the same. With this word, I wish all of you all once again, thank you for the organizing committee. Thank you for all the work coming off the way. We have been picked up from Hubli and coming till here by road because the flights were not there in Belgaum. So they've really taken pain. I've seen the organizers, especially who's in charge of logistic and all that, the way they have been running around to think that we are all of us comfortable and comfort in our traveling. I wish them please on my behalf, all the organizing committee, especially people working backhand, have done a great job. Wishing all the best and may God give you all a healing hand. Thank you.
Thank you, sir. We are always happy to have you.
It is my privilege to introduce a stalwart of physiotherapy professions, Dr. V.P. Gupta, a highly respected clinician, academician, and a national level professional leader in the field of cardiopulmonary physiotherapy. Dr. Gupta has served with distinction as a chief physiotherapist in cardiothoracic and vascular surgery, Department of AIIMS, New Delhi, where he played a pivotal role in advancing cardiopulmonary rehabilitation practice in one of the India's premier medical institutions. Dr. Gupta is also widely recognized for his leadership in shaping physiotherapy standards and governance in India. He has been a member of Delhi Council for Physiotherapists and Occupational Therapies and has practiced in Ministry of Health and Family Welfare expert meetings on minimum standards for physiotherapy centers and currently represents the profession as a member of NCAHP Professional Council, contributing to national level regulatory process. A sought after speaker, he has delivered the prestigious Dr. N.S. Yadava oration, served as a resource person at major events such as BCIPCon and an international conference on advancement in physiotherapy. With a career that blends clinical mastery, academic depth, regulatory leadership, and a lifelong commitment to achieving physiotherapy, Dr. VP Gupta stands as an inspiration to practitioners, educators, and students alike. It's an honor to hear from you, sir. I request sir to address the gathering.
Thank you for this humbling introduction. Uh, Honorable Chancellor, Sir, Chief Guest, Diana Dulji, Ma'am, Dr. Ali, my colleague council members, the whole organizing committee. I thank everyone for inviting me to this wonderful, beautiful city among you all wonderful people for this great conference. As Madam had described the progress in physiotherapy, the physiotherapy is now known to be a contributory, not a contributory, but equally important part of contribution in healthcare in every field, not only in orthopedics, neurology, sports, cardiac, and other fields, but it is in no healthcare field is now untouched by contribution of physiotherapy, and it has become totally imminent that the physiotherapy is going to be a leading medical subject, medical practice in the coming future in healthcare delivery system of globe. I I have seen this growth of this profession since I entered into this profession after quitting my MBBS in 82. So that was a chance I took, and I do not at least regret and I do not repent that I had made a mistake. I really appreciate that the God has helped me. My parents had advised to take on this course, my seniors, my mentors at the time when I had met them. The physiotherapy course has become so prominent globally that, as sir was telling, the mushrooming of colleges, it was out of the demand of physiotherapy profession. Like in such years, when 1982, when I joined, there were only 6 institutions all over the country in India, and the whole batches used to be like migrated to other countries. We did not have physiotherapy professionals in India. In my batch, which was the 22nd batch from IPH, New Delhi, we are only 6 people who remained in India. And we were also offered so many times for the visa for abroad, the working visa for abroad, but we were so satisfied and the conditions are so good. We are exposed to such a wide scope of our practice that the whole globe does not match our professional practice over here. And for that, once in 1994, I remember Dr. Lee was there when we had 91 first conference in Maurya in New Delhi. So when we had proposed for a council, at that time we had only 112 members, life members of physiotherapy association. And then we made a drive, we collected the data and presented to the ministry. And from that time onwards, like 1996, then 2000, 2002, 2005, 2013, and now the dream has come true. The first milestone we have achieved in the history of physiotherapy, the very important milestone. So this milestone is the first step towards the regulation in physiotherapy, because discipline is very important for the growth of every profession and in life also. So that discipline we have to maintain, and we are sure that physiotherapy will make its own way by taking this step onwards, and there are no regrets that we have been so delayed in getting this council, because we have gone through so much of experience that will help us in reshaping and reorganizing, remodulating physiotherapy profession to the match of the global standards. And India will be the hub of physiotherapy professional practice, a role model for the whole world. And still, in some cases, this is there. The people are coming, people are looking for the India. WCPT has great representation of the Indian physiotherapists, and they are contributing their best in shaping the physiotherapy professions globally for the service of mankind. So this conference is an international conference. The delegates from all over the globe are here, and the scintillating atmosphere, the academic atmosphere which it has created, I thank the organizing committee for making me the part of it. I have really exchanged my views with some of the legendaries. The students have must have been getting the chance to get the legendaries in their contact. The world leaders are here in this conference and have undertaken the workshops and CMEs. So you will definitely get an benefit and will shape your future with new innovations, new visions. Your mentorship is there, your legends are there, your vision the council is going to create, and you all are the part of the council. So do not think that only we are the part of the council. You are the important unit of the council, and each unit makes a difference in reshaping the council formation. So thank you again for making me the part of this. And I really enjoyed and appreciate the efforts of the organizing committee in making this wonderful event. Thank you.
Thank you, sir, for your valuable words. Our next guest is Dr. Ashish Kakkad, Professor and Principal at Faculty of Physiotherapy, Marwadi University, Rajkot. He holds a bachelor's and master's in physiotherapy with specialization in neurological conditions and a PhD focused on developing a predictive model for post-stroke recovery. He has also contributed to innovation through stroke recovery predictor mobile application funded by iCREAT. A recipient of the Significant Contribution Award and Young Achievement Award from IIP, Dr. Kakkad is also an accomplished author. He has written the textbook Fundamentals of Electrotherapy and Biomedical Physics and has contributed to 4 book chapters in the areas of stroke rehabilitation and physiotherapy. Sir, we request you to enlighten us with your words of guidance.
Thank you, ma'am. So, good afternoon to all the respected dignitaries, faculty members, and future physios. I mean, future physios mean students. So, first of all, it becomes very difficult to speak something after so many of our seniors and even my teachers. They have given you a speech. But for our future physios or the students, I would like to say whatever it is required as a part of today's era. Like even new education policy, it says about the multidisciplinary education. So I would like to say to all the students, like, don't restrict yourself only to clinical part or academic part, because when we think of physiotherapist, so we always like think of someone who is doing practice in clinic or someone who is working in hospital. Few of us like academicians, we are there. But nowadays there are many other scopes where the physio can go, and you may continue with your physiotherapy knowledge only. For example, full-time researcher. Like if you compare with the other fields, so we have many full-time researchers from physiotherapy field. I have seen one of my colleague, he has entered into the this machine world. Like many a times you see the stalls outside, so he is designing machines for physiotherapists use only with the help of biomedical engineer. Many senior physiotherapists, they work as entrepreneur and start the chain of the physiotherapy clinics, or you are working as entrepreneur, like franchisee you are growing. Okay, you may go for after your graduation, you may go for LLB also. So you will be required at many of the insurance company for medical legal cases. Many of us, they are also doing hospital management. So your role will be there in the management also. Many of our physios, they are doing intraoperative neuromonitoring in operation theater that we have seen. So even the neurologists, they require your presence when they want to operate any neuro structure in the surgery. Okay. Recently, I heard one of my student, she has started digital physiotherapy. So she is creating content for social media, which gives education to the patient. Okay, obviously we are aware about the telerehabilitation and all. So you think something that is obviously somewhat added to this traditional practice, because you are the future of the physiotherapist. Okay, so start thinking in all these dimensions. Like I was thinking whether should I add or not, but already sir added, like our physiotherapist may be in legislative assembly also, already there in parliament as a physiotherapist. So the future of the physiotherapy I can see here. You should start exploring the different fields where you can serve and you can work for the promotion of the field. Okay, so at last, not taking much of your time, I would like to thank Dr. Vijay Kage sir for inviting me and to give this platform to convey this message to all of you. Thank you so much and have a bright future. Thank you.
Thank you, sir, for your insightful words. We are honored to introduce our next guest, Dr. Ketan Batekar, sir, who heads KB Spark Sports Physiotherapy Aqua Rehabilitation Center in Goa. He holds a master degree in orthopedics and sports physiotherapy and has pursued PhD in physical medicine and rehabilitation from Spain. His professional experience includes serving as a physiotherapist for a Goa Ranji team and a head physiotherapist for the Football Unity World Cup 2015. He is an author of 2 books and has held a position of General Secretary of Indian Association of Physiotherapists. Sir has received numerous awards: Excellence in Aquatic Physiotherapy Award, ICPT Award, Physio Excellence Award, Men of Series Award, to name a few. We now request Dr. Ketan Batekar, sir, to address the gathering.
Thank you, ma'am. Very good afternoon to all dignitaries present on and off the days. Respected Ali sir, the woman whom we has empowered the all India team, and as congratulations to you for the winning World Cup recently. It's the foundation which was led by Dr. Ali Irani for physiotherapists, and the foundation which is led by you. Ali sir gave us the council and you gave us the World Cup. Congratulations to both of you. Dr. Prabhakar sir has just left now, but I believe that the person whom I am here because of 2 individuals I have come to Kelly. I hardly attend any conferences these days. And I have come because of Dr. Kore sir and the person whom I admire and I respect the most, Dr. Sanju Kumar. I think I've seen him from 2011. I've been part of Kelly from 2011. I've been part of Kelly from 2011, and first time I met him and we met Prabhakar sir and we gave our level best for the Physiotherapy Council. And I believe Prabhakar itself, the name Sanskrit says enlightenment, light, aura, optimism, positivity, and an enhancer and influencer. I believed when we did go to light the lamp, the name itself says light the lamp. And he said, he gave it to us. And while going again after finishing the lecture, he said, thank you for calling me in my own house. That shows the humbleness, and that's how we physios need to grow, with a lot of humbleness in life. I'm very happy that my principal, Dr. Ravi sir, is there down, and my sir Prashant, my SDM friends, Dhaval, Vinuta, and all the individuals here who are there. Very honored to be in, with you all. I've learned a lot from you, and I have learned a lot from people sitting here, Deepa and VP sir, Gupta sir. I think if I name anyone and everyone, there'll be a lot of time. But I do remember names, and I'm happy that Capri sir was felicitated and awarded today, Deepak Capri. But the real reason for Deepak Capri sir to be awarded was because he has paid the highest income tax last year. So as a physio, I feel proud when I meet Deepak Capri, because the amount of good work what he does and the amount of income tax he pays or he does not pay, I know how much he earns. But that is how a physiotherapy needs to grow. And as ma'am said that every team needs a physiotherapist, I said every individual today needs a physiotherapist, madam. It is from prenatal to postnatal, you need a physiotherapist. It is from madam to Virat to Dhoni, who falls on the ground. It is the physio who runs on the ground, sees the ground, assesses the player, and without MRI, CT scan, injections, sees the player is fit and plays the game. If in Olympics, if you try to win a medal, it is the physiotherapist who is there, goes there, wins a medal. Though we do not get the credit, we are like a credit card who swipe, but we don't pay the dues. So still we are due affected people, but we are happy that the due is coming slow and steady, and we are getting what we really acknowledge for. Today we have seen the physiotherapy college in KLE is growing to a different level. I always believe that today physiotherapy has grown to a different level. We need to understand that there are I will not name any professions, but there are professions which study only head, neck, and brain. But it is the physiotherapist which studies the complete BD Chaurasia. Head, neck, brain, thorax, abdomen, upper limb, lower limb, insertion, root, nerve, everything. So, physiotherapy is growing to such a level that बच्चा पैदा होने से पहले बूढ़ा होने तक, बच्चा रोने से पहले बूढ़ा रोने तक, it is a physiotherapist which gives relief without painkillers. It is the physiotherapist which makes you walk. I always believe from supine to prone, from prone to sitting, from sitting to standing, from standing to running. It is the physiotherapist who gives the range of motion also. No surgery, I can vouch for it. No surgery is successful without physiotherapy pre and post. It is a range of motion which the physiotherapy deals with. I always believe when Shah Rukh Khan also does this and bolta hai kya kya hota hai, kuch hota hai. I always see the abduction, adduction, internal rotation. That is how physiotherapy is growing. So we have to progress. How can we progress? Not by competing about how many colleges we have, but how many good physiotherapists we have. The quality of physiotherapy makes a huge difference in life. And I think the quality is by learning, by giving evidence-based studies, by not defeating your own physiotherapist, by trying to bribe his own private visit. Grow yourself in such a way that don't try to compete Deepak Capri. Don't try to be best, but learn from Deepak Capri and understand that yes, you can be a Deepak Capri. I think the physiotherapist हम हमेशा एक दूसरे को खींचने में ही हमारा आधा टाइम जाता है, एक दूसरे के बारे में गंदा बोलने में अलग टाइम जाता है, और इन दिन तो ऐसे कैसे कायरो प्रैक्टिस आए हैं जो मतलब टक टक आवाज निकालने के लिए ऐसे ऐसे मॉडल को लेके आता है कि वीडियो देख के भी बुरा लगता है कि हम यही सीखने के लिए आए थे क्या करके. I speak what I speak from my heart, and that is the only reason might be I'm bachelor. Why we need to take models to do chiropractic is still what I have not understood. Why we need to show those models? I think practice on yourself, give range of motion, increase the relief, and grow yourself. All the senior physios sitting here, they have not even gone to any social media to put any videos, but they have got good patients, they have got good relief, they are known worldwide, they are understood worldwide, they are loved worldwide. I think Dr. Ali Irani, I saw him in 1996. I have told him in many things. And I asked my mother, the person, who is this bald person running? He's still bald, but see what sir told. 30 years, this person is not leaving the chair. That is physiotherapy. That is because his love towards the profession, his growth towards the profession, helping everyone in the profession, increasing range of motion in the profession without taking any models, because he himself is a model. I think that is where the profession grows, and I am very, very happy to understand today. I came into physiotherapy because of Dr. Ali Irani, and still people are getting into physiotherapy because of Dr. Ali Irani. So I think if you build your aura, if you are an answer, if you are influencer, if you are optimistic, if you know only to grow positively, if you grow positively, trust me, profession also will grow positively. I always say कि खंजरों में क्या रखा है, निगाहों से प्यार करो. भाई खंजरों में क्या रखा है, निगाहों से प्यार करो. भाई एरो गैरो में क्या रखा है, फिजियोथेरेपिस्ट बनने से प्यार करो. Love yourself so much. I met Sanju Kumar sir 2011. Sanju sir, I know him from 11 till 25. One thing has not changed in him. Ketan, conference है, तू आने का है, आता है, नहीं आता है, time है, नहीं है, कुछ नहीं, तू आने का है, and phone cut. That is what Sanju sir is, and he is the only person who can do this to me. And I have seen physiotherapy in one room, and I have seen physiotherapy today expanding in Kelly, and I'm proud about it that I'm part of Kelly. When my first aqua therapy workshop was under you, you gave me that platform, and I will never forget that. After that, I went to Kent Brasoots in London. After that, I went to Singapore, and after that, I went into politics doing aqua therapy. But everything what I did was because of two institutions. One is SDM College of Physiotherapy, and one is Kelly. And it's because of you, Sanju sir. I would never forget whatever I've achieved today. I'm still grounded. I will always be grounded. I know that, whatever you have given me in life without expectations, though I'm not part of any conferences of physiotherapy, but still you called me, gave me the platform. I need to reach Goa today at 4 o'clock. I have some functions. And yes, as Prabhakar Kore sir said, I promise you today, within 2027, I will come back as an MLA, and we will have a physiotherapy college under Prabhakar sir in Goa. That is my promise to you. So, last but not the least, let's grow as physiotherapists. For in every field you need physiotherapy today. Government spends crores of rupees to see trees are not cut. When trees are not cut, I think humans also should not be cut. And if you don't want humans to cut, it is a physiotherapist only can help you without side effects, without painkillers, and improvising range of motion. So before leaving, my thanks to everyone sitting there behind the curtains who have worked so hard, everyone sitting in front who are clicking our pictures, and every physio. Life is like समंदर में तैरने वाले लहरों का इंतजार नहीं करते, सीढ़ियां चढ़ने वाले ऊंचाइयों का इंतजार नहीं करते, और जो ऊंचाई चढ़ते हैं उन्हीं को फिजियोथेरेपिस्ट कहते हैं. बिलीव मी, ट्रस्ट मी, वर्क हार्ड, learn your subject hard, and last but not the least, before leaving, my thanks to Kelly, my thanks to every single SDM staff here, my principal Ravi sir again, because you have been part of my life, and I would not forget the Michigan tournament, what we have done under you, learned, and I still remember your number also, but I would not say it because you should not get calls. And all the individuals, Madhugud sir, Deepa, and everyone sitting here, thank you, have been a great part of Kelly. And last but not the least, I would just finish my statement before saying कि जीना है तो उन गुलाबों जैसे ना जियो जो मुरझा जाते हैं, जीना है तो उन गुलाबों जैसे ना जियो जो मुरझा जाते हैं, जीना है तो उन पत्थरों जैसे जियो जो तराशने के बाद भी खुदा कहलाते हैं. Thank you.
Thank you, Dr. Ketan, for having that adrenaline rush in everybody by your speech. So we draw the inaugural ceremony to a close. I invite Dr. Ganesh PR, Organizing Secretary, Pearl Physiocon, to deliver the vote of thanks.
ಎಲ್ಲರಿಗೂ ನನ್ನ ನಮಸ್ಕಾರ. I should thank my respected first teachers, Dr. Swain and Dr. Alpan Kandarwal, who are here for this conference, without whom these 30 years would not have been possible. The graceful end is an important and a grand beginning. With this thought, it is my privilege and honor to deliver the vote of thanks on behalf of the Organizing Committee of Pearl Physiocon 2025, hosted by Kelly Academy of Higher Education and Research, Institute of Physiotherapy. Esteemed Chief Guest, Mrs. Diane Edulji, former captain of Indian Women's Cricket Team, Arjuna and Padma Shri Award. Madam, your presence has added immense value to this inaugural function. Your inspiration words on perseverance and excellence will certainly resonate with every budding physiotherapist here. We are truly grateful for your gracing this occasion. Thank you, madam. Our distinguished guest of honor, Dr. Ali Irani, member of Physiotherapy Professional Council, Government of India, and ionic figure of in Indian sports physiotherapy. Thank you, sir, for invaluable insight and lending your stature to this conference. Thank you, sir. A special thanks to our Dr. V.P. Gupta, Ashik Akkad, and Dr. Ketan Bhatekar for a wisdom of words. Thank you. A heartfelt word of the grateful to our Honorable Chancellor, Dr. Prabhakar Kore, whose unwavering encouragement, the leadership, and commitment to academic excellence have made it possible for us to host this event of this magnitude. Sir, we remain ever grateful to your vision. I extend my sincere thanks to all our respected dignitaries, faculty members, speakers, and all delegates from India and across the globe, and our passionate students. Your participation enriches the scientific value of this conference and strengthens our collective mission of advancing physiotherapy. Thank you. To the organizing committee and volunteers, administrative staff, and every silent contributor who worked tirelessly behind the scenes, this conference stands as a testament to your dedication and impeccable coordination. Thank you for turning months of planning into smooth event. Finally, to our wonderful audience, thank you for your presence, your curiosity, and your commitments to learning. Your energy is warm, is what truly makes this Per Physiocon 2025 meaningful. We look forward to an enlightening and impactful series of sessions over the coming 2 days. Thank you, one and all. I also request to all of you to visit our uh, Art of Physiotherapy OPD located at our Kaili Hospital. Please do visit. Thank you.
Thank you, Dr. Ganesh. We now present a brief video showcasing Kaylee's visionary dream project at Hubli, a state-of-art 1,000-bedded super specialty hospital, along with the establishment of second physiotherapy college. This transformational initiative reflects Kaylee's commitment to advancing healthcare, education, and service to society. Let us take a look at this inspiring journey. I request the dignitaries to please step off the dais. Thank you. We request everybody to raise for national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you, one and all. With the inauguration now complete, we look forward to an intellectually enriching, collaborative, and transforming conference experience. Our next session is by Dr. Deepak Kumar Kepri, sir. We have the next talk by Dr. Deepak Kumar Kepri, sir. Delegates, there is a slight change in the schedule. We would now have the talk by Dr. Ali Irani. I request the delegates to please be seated. We would break for lunch at 1:30. Delegates, please be seated.
I kindly request all the delegates to be seated. I kindly request all the delegates and the dignitaries to be seated as we are going to have a talk by Dr. Ali Irani.
हो थांब. और एक मिनिट. सर निवा ये. ಯಾರು ಹೇಳ್ತಾರೆ ಸಂತೋಷ್ ಕರೀಲಿ. ಏನ್ ಮಾಡಿ No, no, you use. Please share your. Okay. Yeah, share. Share.
I don't.
ಸರ್ ಇನ್ನೊಬ್ರು ಯಾರು ಚೇರ್ ಪರ್ಸನ್ ಯಾರಿದ್ರು ಹೋಗುದ ನೀವು ಕೂಡ ಹೋಗ. Our next speaker is Dr. Ali Irani. Served as physiotherapist for the Indian cricket team 1987 to 1997 and researcher at Bombay Hospital. Sir is a professor and PhD guide at multiple universities including NMIMS, DY Patil and Toronto University. Sir has presented research and conducted workshops globally on physiotherapy, sports medicine and disaster rehabilitation. Sir has established physiotherapy centers for earthquake victims and promoted community-based rural physiotherapy. Sir is a recipient of major honors including the Lifetime Achievement Award and Best Physiotherapist Award. Sir holds membership in leadership roles in Indian and international physiotherapy and sports medicine organization. Sir, we welcome you to take over the stage to chair the session. To chair the session, I request Dr. AKJ Sinha sir to please come on the dais and Dr. PC Swain sir to please come to chair the session. So off to you.
With your permission. Thank you. As the theme of the conference is using innovation, part of physiotherapy. So my subject would be physiotherapists no more give ultrasound and diathermy. So we have entered people's brain and we can do brain mapping. I strongly believe that a tongue can lie, but brain cannot. So the signals you can get from the brain, you can learn a lot about the patient. All of us sitting here have two sections of brain, the left and the right. All of us have that. But the difference, what I always say is, the left side is more like a male brain. They work in boxes. They will only do one particular thing, finish it, and then go to the next box. But only a female can do multitasking. Sitting here, you're already planning what time is the lunch, where to go, what places to see, when we can get rid of this place. The multitasking is done more by females, but we all have this section of the brain. Brain consists 20 billion neurons, which generates electrical impulses. That is what we read about it. And it's measured in hertz, that is frequency per second. This is how an EEG done would look to you. And the machines were too big. You could see a whole room was required to do an EEG. But with technology, that's the traditional EEG units old. But with technology, the portable EEGs have come. And we use only 3 electrodes, which is on the forehead. And with that, we can read. Why we are selecting the forehead? Because when we forget, we bang our forehead. So that means all the thought comes from there. So we try to see that we can collect it. These are the electrodes. You can do it in lying down position. You can take it in sitting position. And 2-channel portable EEG has been used roughly to show you how it will look. We are converting, there's a software where the EEG frequencies, the hertz, are converted into mushroom, taking an average. So if you look at the mushroom, they are the average ones of EEG, the hertz frequency that we measure in hertz. The hertz are converted into mushroom, the average ones. Just a video of it, how it will look when we are doing a brain mapping, using only 3 electrodes on the forehead. So we can just do it on any individual. And I will just tell you all how the brain works. We have 5 zones that our brain works on. But roughly, this is a picture when we are going to do a brain mapping on anybody. So we have 5 zones. Delta, which is less than 4 hertz, you are fast asleep. It is deep sleep. And between 4 and 7 is theta, you are semi-conscious, especially when you are dreaming. In dreams, you are in theta. Alpha is one of the best zone, 8 to 12, then beta, lot of anxiety, confusion, not focus, and similarly gamma, 29 to 40 hertz per second, right? So what are the qualities when you want to separate them? In delta is deep sleep. Only in red I'm giving you so to, as a physiotherapist, you'll understand better. And theta is dreams and during meditation also you can go in theta. Alpha, you are focused. We use it for healing. If you take the patient into alpha zone, the healing is faster, healing is better. Once a patient comes in beta, there is excitement, stress, anxiety, fear, rage. We found out in sportsmen who have not performed well, they have always been in beta or gamma. I took it on my own students. When they have performed well, they were gold medalists. Asked them to imagining the subject that they got a gold medal. When they were writing, they were in alpha zone. And the students who have failed, when I asked them to think about that, they are writing the paper and they have failed, they were in beta and gamma zone. So beta and gamma are the one that you are not focused. So whole idea of this study was to show that if you can get the sportsman into alpha zone, they perform better. And if you can get the students into alpha zone, they are going to perform better. So just showing you the different zone, how it will look on EEG is down, and this is how it will look on our application doing the brain mapping. Then coming to theta, you will see the slopes increasing because the frequencies per second have increased. That is theta. And then what we really want is alpha. This is how it will look on the EEG machine. But we have got software which converts it into the average one. What is look like mushroom to you is the application showing it. And we do help it. It's better in positive healing. Awareness is there, enhanced focus, and we use it in neurological condition for healing. Beta, as soon as you see it spread all over, you'll see we are shifting the zone more towards the right, towards beta and gamma. There are high complex mental functioning happening associated with strong excited emotions, anxiety, attention, concentration, and most of the hypertension patients are also in beta. And gamma, you see the number of frequencies, it goes up to 40 frequencies per second, like 40, 42 hertz. So it's no doubt the person is in awake state, too many thoughts, seen in anxiety, person cannot focus. We are searching. What we found out that all people 60 plus, senior citizen, when we do the brain mapping, they are more towards gamma. You must be listening to your parents and grandparents when you meet them. They tell you stories about their college, their school, right? So they go back to that age. So we are still trying to get more subjects and find out why all senior citizens are in gamma. We just put them anytime in brain mapping. We see them, they are in the gamma zone. Just again to review what this zone, we all stay, we are alive in this 5 zone. Either we are in deep sleep, either we want to awake or we are dreaming. Alpha is your focus, And beta, you start, there's excitement with stress. We are not focused at all. There is a rage. And again, gamma, same like beta, but we are still studying. It's under research for more patient. Why we use it for sports? It's our study started brain mapping in sports because one, the sportsmen lie a lot. Even if they are not injured, they will say they are injured if they don't want to play. And if they are injured, they will tell you they are not injured so that they can play the game. So I will be showing you the slide how we make out if they are telling the truth or lie. Because sports is competition, there's a constant pressure, there's a fear of failure. That's how they function. If there was no competition, there wouldn't have been sports. And peak performance is required for excellence in competition. So there is a stress, extra stress in the sportsman to perform. So, as I said, we have found out all the sportsmen who have performed well, they were in alpha zone. And when they have not performed well, they were in beta or gamma zone. So, a case study of an injured sportsman brain wave pattern we saw, right? So, if I have to show you all, I don't need to ask a sportsman is injured or she's injured or not. This is the complex. This is how the slide will look when we are doing a brain mapping. But you will see more towards beta and gamma, right? That is straight going to show they are not going to be in alpha at all. And Alman said in 1992, peak performance requires a special state of intense concentration, which is alpha activity, alpha zone. So main focus of our whole study was how can we get into alpha zone? Alpha is a zone of staying, to be alive, to perform, to study well, to treat well and get better concentration of the patient. So we did on a cricketer, we did a study. The cricketer didn't know we are doing brain mapping. So we just put that this is a slide we got. The subject not knowing it's brain mapping, right? We got this, then started talking to the patient using all our tools to get him into alpha zone. Now, after we got the alpha zone, the first match that he went to play, it was weekend matches. So in the first match, he got 4 wickets, 32 runs, which was the career best for that bowler. The second week, when we took 3 wickets, 3 runs, again was career best. And third week, 2 wickets, 40 runs, but they won the cup. And the fourth week, 6 wickets, 22 runs, again career best. So this was when the patient was in this zone, clear, clean alpha zone. So if we can get a sportsman in alpha zone, right? I hope Dinah will give us the opportunity to work more on the cricketers to get them into alpha zone. And then, but it's very important when you are talking to your patient, if you understand one thing, remember meditation is alpha zone. If you can get yourself in good meditation, whichever technique you use, you will be in alpha zone. No doubt the pharmacies are trying to work out whether they can give you a tablet. After taking the tablet, you will be in alpha zone. I want the telephone bills, the mobile rings. When it rings, you should go in alpha zone. So one of the things what we saw, it's not sound or music that takes you in alpha zone. Any vibration sound, like I don't say the word Om, how you say that word Om, how much of vibration you can give it, that is important. That can also take you in alpha zone. So this was how the sportsman was in peak performance. Pure alpha, clean alpha, no disturbances, no gamma, no beta, nothing around you. And pure alpha, you are definitely going to perform very well. So just on a video to show you all how alpha zone will look, right? So we look more towards the right side. There shouldn't be any gamma, there shouldn't be any beta zone. If you are going towards the center, a little more towards the left, you are on perfect alpha zone. So the brainwave pattern of various sportsmen was studied, and whenever it was between 8 to 12 hertz, which was the alpha zone, and we saw the peak performance in the sportsmen. And when the sportsman did not perform well, the brainwave showed high activity in beta or gamma zone. So physiotherapists today not only prevent or treat injuries, but also must prepare the sportsman to be in alpha state or alpha zone for his or her best performance. So I believe that brain mapping will be a new tool for physiotherapists, especially those who are practicing in sports medicine. So we have 2 units of it. One, we only use it for neurological patients, especially hemiplegia. We get them into alpha zone and then treat them. The results are much better. And in sportsmen, of course, from day one, we ask them whether the injuries, about injuries, when we are asking them, we come to know whether they are really faking the injury or they are really injured and see in which zone. We ask them to imagine any best game they have played. We saw that whenever they have performed well, they were in alpha zone, and when they have not performed well, they were in beta or gamma zone. Similarly, with students, we have done it. Students who have excelled, who were in the first 3 rankers, they were in alpha, and all those who have failed in any subject, when we told them to imagine they are writing the exam, they were in beta and gamma zone. So for all of us, alpha is a zone of living. How to come in alpha, you can read more about it. And hopefully there are a lot of other workshops which can get you into alpha zone. Thank you. God bless.
Thank you, sir. It is a very new knowledge. As far my knowledge goes, I don't know about others, and it's absolutely a very good area. And things are very well. We have gone through the what do we say regarding the diagnostics and its implementation in practices. But I have one query here, sir. Can you use this in neuro rehab or psychosomatic rehab, sir?
See, when you see a neuro patient and we do a brain map, any of us sitting here, we do a brain mapping, not necessarily you are in alpha. You could be in beta, you could be in gamma, depending on your thoughts that is going on in your.
Yes, sir.
So getting the patient first in alpha, it's in our words was relax the patient, ask the question to the patient, see if the patient is comfortable, have your bedside right, is the patient doing well, come, then you start treating. So that itself, these are the things which may be putting the patient in alpha
Very
zone.
true. Very
But
true.
there were no parameter to find out whether really the
Yes,
patient is alpha
yes.
or not. So through brain mapping, we would find out that the patient is an alpha or not.
Yeah, this is a very nice area. Actually, quite a good number of psychosomatic patients or any neurological patients, when you are dealing, will come across patient will have anxiety, some sort of feeling that they may not be the ability what we are planning to train them and etc. And if we can diagnose them at what level they are with respect to these signals, so then like it will be easier for us to get them to the level of signal where they can work on it, and then we can proceed with the further training. It's a very good work, sir. Thank you. Thank you, sir.
If there is any query from the audience, Dr. Irani is open to your comments, your questions. अरे तुम लोग तो अल्फा में आओ, कुछ पूछो. Dr. Irani, there are some people who have a knack of doing something new. And Dr. Irani has a knack for introducing something new. I remember way back, he introduced the concept of fitness. And that fitness is now everywhere. And this brain mapping thing, which he's introducing since last 3-4 years, I hope in the next few years, it will also pick up like fitness. It is always pleasure to listen to Dr. Irani. Thank you very much, sir.
Thank you, sir.
Beautiful presentation.
So the instrument, the portable EEGs are very costly. I think so that's why it's not multiplying very fast. Once India starts making it, I think so every physiotherapy center would have it. Some new studies are on grounding, on frequencies, on. So hopefully next conferences I will be showing something new to you.
Yes, sir. Actually, this is a very good work, and let us keep on working. And I hope that will give a different new thought and light to the physiotherapy profession as such. So it is not only applicable to neurological sports conditions. It can be implemented to other conditions, because wherever we work, we come across some amount of either patient or therapist or other things. We come across different things, and that can be used. And as you said, the equipment, other things, I think it will not be very difficult in coming days because semiconductor and other things are improving very at a very faster rate, and things may be far easier for us to get the new equipments to deal with the patient's problem. Thank you,
Sir,
sir.
because
Thank you for being light.
I believe कि दुनिया झुकती है, झुकाने वाला चाहिए.
Sir, correct, sir.
Thank you all of you. Thank you. God bless you all. Happy learning next 2 days.
Thank you very much, sir. I request the chairpersons to please present a token of appreciation to Dr. Ali Irani, sir. I thank the chairpersons for chairing the session. We can break for lunch and resume for the next session. And come for lunch.
Hi, sir.
That so I can plug my computer and check. No, I don't. I think Doctor. One after that. Just straight HDMI.
Yes.
Can I bring my computer here and quickly
Yes.
try? Whilst no, I know exactly what. I don't need to make sure. Check. No, just to make sure. Waste time. You've got to make it 30 minutes. 30 minutes.
How are you?
Bad.
Yes, and let me change colors. What what refresh rate do you want? 60, 80? Why don't I just go? I just no, that's perfect. I change. Okay.
A very good afternoon to everyone. We start with a post-lunch session. And to chair this session, I request Suzanne Everett to chair the session, please. Suzanne Everett is a sports and musculoskeletal physiotherapist from Sports Med, South Australia. She's invited physiotherapists to the Australian track cycling team, including Sydney Olympics. She's also invited physiotherapists to the Australian rowing team, including Athens and Beijing Olympics. She's founding partner of SportsMed Multidisciplinary Sports Medicine Center in Adelaide in 1989, where a conque to race is a partner, CME lecturer, and part-time CME lecturer, and a clinical supervisor in University of Australia on sports medicine and musculoskeletal master's program. We welcome you, ma'am. Asha ma'am. Our next chairperson is Dr. Vaibhav Dolas from All India Institute of Medical Sciences. So we welcome you to chair the session. I would like to introduce our next resource person, Barry Getz, who is sports and orthopedic physiotherapist, Johannesburg, South Africa. Getz is a senior sports and orthopedic physiotherapist with over 25 years of experience in private practice in South Africa. He is a partner at Leacher, Speechley, Davidson, and Partners Physiotherapy with branches at the Center for Sports Medicine and Orthopedics. His clinical focus is on lumbopelvic hip complex and lower limb injuries, managing sports, orthopedic, and post-surgical cases involving the hip, groin, knee, and ankle. Barry has published and presented internationally on hip and groin rehabilitation and serves as a reviewer for Sports Health Journal, Journal of Hip Preservation Surgery, and APTA Orthopedics. He has worked with numerous international and national sports teams, including South Africa, France, Australia, Wales, Japan, Rugby League, and various South African football teams. Barry is an active member of HPCSA, SASP, ISHA, SASHA, and SASMA. Sir, all to you. Thank you.
Good afternoon, everyone, and a big thank you to all the organizers and my colleagues who are here today. It's lovely being hosted in India again. I truly enjoy everything, and I'm really, really inspired to be here once again. So today we'll be talking on the continuum of hip preservation, what's happened in the past, and where are we going to go? Where are we going to? So I've got no financial disclosures for this talk. The big question everyone asks me is, what's so important about the hip? Well, if you're anything like me who's passionate about that joint, the hip is only the third largest weight-bearing joint in the body, and it connects your lower limb to your trunk. But the beauty about the hip is never fully offloaded. So whether you're sitting, standing, lying, that hip is always under some sort of biomechanical load. So you can't just pop it in a sling and rest it. You can't put it on crutches and rest it. It doesn't work. So let's start and let's try and catch up a bit of time in that regard. So what we want to do today is we're going to explore historical foundations of hip preservation, which is primarily surgical. Then we'll review the current diagnostic and treatment techniques available, and we'll examine some of the innovations that will shape our future and hopefully add physiotherapy's perspective to this entire mix. So the birth of hip preservation dates its origins back to the 20th century, when early limb-sparing operations were introduced as an alternative to more aggressive surgeries that disarticulated the hip. In other words, they mutilated the hip to try and repair it in an attempt to correct deformities such as congenital hip dislocations. By the late 19th and 20th centuries, these approaches had evolved into procedures like the girdle stone resection and hip fusions, commonly used to treat severe arthritis and long-standing congenital abnormalities. The modern era of hip preservation began in the 20th century as well, and it continues well up until today, marked by significant advances in understanding hip pathologies. During this time, clinicians have developed a deeper appreciation of hip biomechanics and the role of structural abnormalities in the development of early degenerative disease. A defining breakthrough was done by Reinhard Ganz in 1990, when him and his colleagues identified a condition called femoral acetabular impingement and demonstrated its connection to hip osteoarthritis. Later on, Ganz and his group introduced a fairly larger surgery called the periacetabular osteotomy, when we fracture the pelvis to try and reorientate that acetabulum, which transformed treating acetabular dysplasia, and it has advanced into modern tools. But concurrently in 1988, Richard Villa from the UK performed the very first hip arthroscopy, and he went on to refine and popularize this technique as we know today. And it's a less invasive technique as a manner of managing intra-articular pathologies. So physiotherapy, let's not forget, because we were also there from the beginning. I mean, we go back as far as the 18th century in physio. So if you look at the work of Clement Joseph Tissot, where he promoted the use of remedial gymnastics to treat surgical and orthopedic conditions. And by the early 2000s, physiotherapy then emerged as a core component in hip preservation, with targeted exercise programs to improve strength, flexibility, and joint stability, as well as overall function whilst decreasing pain. But growing research has continued, and it's strengthened the evidence base for that. If we look at the organizations involved with hips, professional organizations have actually shaped where we are today. So the establishments of groups like ISHA, now known as the International Society of Hip Preservation, formed global collaborations, education, and research, accelerating the progress in both surgical and non-surgical arenas. So collectively, all of these subcategories of societies in each country have contributed to the innovation of diagnosis, surgical techniques, especially rehab of recent, and scientific understanding. Let's delve a bit into what we've learned in early management, which is non-surgical. So if we look at symptom-focused care, well, this aims primarily to reduce pain and instability and is often used as a temporary measure, particularly in cases such as hip fractures. before that patient embarked on definitive surgery. And that then moved on to bed rest. So patients were often for hips just put in bed and said, rest. Let the mechanical stresses of the hip relax. And patients were positioned in a supine position. They had to avoid all flexion techniques, and they were advised not to cross their legs. And that was the sum of the existence of treatment. Then came bracing, external supports that were there to stabilize the hip joint and limit movement to prevent worsening conditions. We then move on to traction, which the surgeons love, whether they were using skin or skeletal traction. And that was for the same reason, just to allow biomechanical forces to relax. We then have a myriad of medications that are offered, from non-steroidal drugs to muscle relaxants that are commonly used for pain reduction, inflammation, and so on and so forth in terms of cryotherapy, compression, etc. But physiotherapy by this stage was already doing targeted exercises, not in and around the hip, but more proximal and distal kinetic chain to maintain the function of the patient whilst on bed rest. And we found that it released spasm, pain, improved just general overall function. But there were gaps in our early understanding in hip biomechanics. And historically, we had a significant lack of understanding in the structural stability of the hip, as we see in hip dysplasia, especially muscle imbalances and how they alter range of motion and how that contributes to pathology. Also, there's an interaction between the hip and groin, the spine and the hip, the shoulder and the hip, and it goes on and on and on. So surgical foundations in the past were designed to maintain the native hip joint by improving load distribution. They'd enhance both stability and functional movement and the delaying of the onset of arthritis. This involved cutting and repositioning of bones to correct joint abnormalities, such as your DDH, your Perthes disease, which we often see in our young kids and later develop in adulthood. This repositioning of the pelvic bones improved the coverage of the femoral head, whilst femoral osteotomies adjust the alignment or rotation of the proximal femur to optimize that joint congruency. In all of these instances, major bony cuts meant healing is gradual and typically supported by medication and weight restrictions. In all instances, physiotherapy has been graded through its prescription of prevention of secondary pathology, be that respiratory or even vascular. But again, targeted exercises are still there, focusing on strength, flexibility, joint stability, and overall function. But what about the young patient who had arthritis? Because usually arthritis was reserved for the elder patient. So the young patient with end-stage arthritis, this was our major conundrum during the early stages of arthroscopy or even hip preservation, because technological advances, biological treatments were just simply lacking. And in terms of cartilage preservation and bony revascularization techniques, the longevity of arthroplasty joints just wasn't there. We were getting maybe 10, 12 years at most. Now today, we're looking more at 15 to 20 years, so it becomes a more promising scenario. But in this cohort of patients, the young arthritic patient, physiotherapy has proven invaluable. Our intervention has limited pain relief, it has limited functional declines, and inevitably many of these patients, yes, they do convert into arthroplasties, but we've kind of prolonged that process so we can gain a few more years. When we look at arthrodesis of the hip, when they fuse it, what they do is they're making the joint stable and in a pain-free position, but that immobile position often leads to mechanical overload in other adjacent areas like the lumbar spine, the contralateral hip, or even the ipsilateral knee. So often these patients who have converted to total hip replacement are suffering with secondary pathologies. If we look at arthroplasty in these patients, it offered a mobile pain-free joint, but young patients are more prone to high wear rates. And the prosthesis may require multiple revision. So what that means is if you've got a 30-year-old patient, you're looking at 3 joint replacements in his lifetime, and he might not have enough bone stock by the time they're in his 70s or 80s to perform another surgery. So as part of this treatment option, symptomatic relief is achieved through lifestyle changes, such as weight loss, low-impact exercises, supportive devices such as your braces or orthotics, walking aids, or even just general physiotherapy for overall function, anything to improve the lifespan of that prosthesis. So that's the past. So where are we now? So modern diagnostic tools such as MRI orthography, CT scans, 3D CTs, motion gait analysis provide detailed insights into the body's internal structure and function to diagnose that condition. So MRI orthography offers enhanced detail of joints with injected contrast gadolinium, while CT and 3D scans visualize bone complexes and structures, as well as aid in surgical management. Motion gait analysis, and you'll hear that there's another talk, I think it's later on today or tomorrow, has also been fairly paramount as it evaluates movement patterns and functionality, and it complements those imaging techniques for a comprehensive understanding of musculoskeletal and neurologic issues. But let's not just forget standard x-rays of the pelvis, because those imaging provide 90% of diagnoses in hip conditions, and everyone here is allowed to send for a standard view x-ray. A quick mention on motion capture analysis. It's quite a fancy bit of equipment, but if you look very carefully on the Google stores, on the Apple stores, there are local applications that have been designed where you can do this just using your phone, and it's a good place to start. But let's look at non-surgical management in the current era. So if we look at physiotherapy, in 2019, ISHA performed an international consensus statement on the assessment and treatment of femoral acetabular impingement. So in this statement, they provided an outline for the assessment of patients who presented with hip and groin pain, but more specifically, patients presenting with femoral acetabular impingement syndrome. And this paper detailed patient progression through staged rehabilitation, with weight-bearing statuses being dependent upon prescribed surgical restrictions. Post-operative rehab initially focused on local segmental stability, and then followed by global muscular retraining, and then eventually return to sports will depend on all the factors such as strength, agility, neuromuscular execution, and sports-specific drills and tasks. If we fast forward a bit to 2022, well, ISHA, which is one of my holding bodies, we came out with another consensus statement on greater trochanteric pain syndrome. And this one primarily plagues females. So what we did in this consensus statement, we provided guidelines for physiotherapy management of patients presenting with lateral hip pain. And that was based on our current knowledge and expertise regarding evaluation of that area, non-surgical physiotherapy management, the use of corticosteroids and orthobiologics, and surgery and post-operative physiotherapy management. But what about physiotherapy? So let's backtrack a bit, because back in 2014, there was a lovely paper that was published, and it was a multi-center randomized controlled trial where they compared surgical and non-surgical management of FAI. And this paper details alternatives to surgical intervention in which outcome measures may be diminished. And in the case where pathology grossly affected the biomechanics, physiotherapy was proven to be more effective as an intervention. And this is where we move still to today, is a lot of FAI is undergoing 3 months of conservative physiotherapy to try and avoid all those surgical cuts. So other types of pathologies that we'll address through preservation, well, we've mentioned femoral acetabular impingement, such as CAMS, pincers, and subspine impingements. We can talk about labral and chondral pathologies, be that labral reconstructions or repairs. We can look at ruptured ligamentum teres or the repair of that labrum and how it will contribute to the cartilage quality. We can look at hip dysplasia and instabilities of the capsule, or even how we can revascularize avascular necrosis of the hip. But all of this has an implication to physio, as every patient must be rehabbed post-operative. If we look at dynamic instabilities, so now we're talking about capsular microinstabilities, very lax ligaments. We can also look at chondral scenarios like your ACT, your autologous chondrocyte implantations, your AMEX or your autologous matrix induced chondrogenesis techniques. If we look at peripheral compartments, we're still treating greater trochanteric pain syndrome and psoas muscles. And in the posterior compartment, as in this picture, we'll deal with ischiofemoral impingements, deep gluteal syndromes, and proximal hamstring ruptures. But let's move into groin pain or inguinal disruption. So we know the groin has multiple points of referral, so does the hip, and they overlap with each other. So there's quite a big interaction between hip impingement and the groin, and even hip and the spine in that matter, based on the Birmingham model on the right. One of the nice things that have come out from Hal Martin in the US is he refers to a layered hip diagnosis. So he regards the osteochondral layer, which is more your structural stability of the hip. He then assesses the inert layers like your ligaments. He moves on to contractile layers such as the muscles, and then your neurokinetic layer. So always, whilst going through your diagnosis, you always have a purpose or a plan in your diagnostic kind of algorithm that you're following. So where does postoperative physiotherapy fit? And we can apply this even to conservative management. So if you look at the little arrow on your right, we talk about a staged approach from maximal protection through to moderate to minimum to functional progressions and then to full function. And we go through all of those in a various way based on the restrictions based on surgery. But we go one step further. We also now objectively decide how we move a patient from stage to stage. We don't eyeball the patient and say they look good, so let's move them along. We actually perform things like functional movement assessments, already which has been proved to be reliable and indicative of function of that muscle. And we don't base these criteria just on time anymore, but also on the location and the extent of the injury that has been there. Dysplasia is a massive topic right now in hip preservation. It's something that we have missed a lot. And we've operated on many patients, rehabbed many patients, but missed the underlying dysplasia. And because it's often misdiagnosed, these patients inevitably become arthroplasty patients, but it can be avoided. So we are trying to push physiotherapy to learn to diagnose carefully so we can get these mainstream diagnostic criteria working for the patient and not against the patient. Other interventions for dysplasia, I mentioned periacetabular osteotomy, the fracturing of the pelvis in 3 parts to reorientate the acetabulum, or even doing a femoral version correction so we can reorientate the femur. And that has a direct relation to the knee as well. So for years in the world of hips, we've been begging knee surgeons, don't forget the hip, because that's where it all begins. We've also come up with outcome measuring tools or your patient-reported outcome tools, PROMs, and there is a myriad of them as well. Anything from HAGOS to the VAIL to the IHOT 12, the IHOT 33, the hip arthritic scores, the modified hip arthritic scores, the list just goes on and on and on. And choosing the correct forms for your practice is quite important. And we can use these at different 6-week stages to monitor patient progression. But enough about the present, because this is all about technology of the future. So where are we going with hips? Education, education, education. And I think that was reflected today from Kelly, which is lovely to hear. So whilst orthopedic surgery is advancing at a phenomenal rate, physiotherapy has somewhat stagnated in the side. And we've operated very much in isolation. We need more in-person training. We need to expose physiotherapists to what is hip preservation. It's not big in India yet. There are very few surgeons actually doing this. As far as I know, there are about 4 or 5 surgeons in the whole of India that are considered experts in this field. So if you take this up now, you are going to be the future leaders within this country, which is wonderful for me to hear. Moving on to more education, but we're looking at artificial intelligence, robots, wearable technologies. Technology integration such as AI to progress. It processes large amounts of information, of patient data, and that can create detailed 3D anatomic models that can help customize surgical and treatment plans and predict analytics for potential complications such as post-operative surgical risk management in patients. The robotic surgery, yes, it aids the implants of the surgeon, but it also means less bone is cut. And that means patients feel better quicker, so function can be pushed much quicker as well. Wearable technologies, I've been contacted about 2 years about this, where we put GPS devices in patients' braces. So we get real-time data of patients as they are moving, sent to our phones. So now we know if they're performing their home-based programs or not. And ultimately, if they start lingering in their techniques, we can give them a little nudge to start get going a bit quicker, or tell them to start slowing down, which is quite amazing in that regard. If we look at osteoarthritis, well, we know cartilage condition is excellent at the time of birth, but gradually declines with age and activity levels. Projected figures for hip arthroplasty is significantly rising year on year. And it's astounding. I was looking just at the growth rate in India, and India still have one of the highest arthroplasty rates in the year, if you look at the registrars of India. But in my opinion, a key feature will be to understand its impact on exercise, especially in our children, and how that may influence cartilage condition and degenerative progress. So through the understanding of hip mechanics, one would be able to ascertain which patients are at high risk. So we would be able to determine the future implication for the onset of arthritis. But let's think a bit out the box for a bit in these OA people. For example, if we use AI in CT and MRI studies, maybe we'll be able to produce hip collision studies. We've had a bit of it, but it hasn't been that effective, and that will provide valuable information on secondary compensations within the lumbar spine or the sacroiliac degeneration in that regard. And as I said, the same would apply to the knee. What about biologic therapies? So stem cell therapy from either bone marrow or adipose tissue. Well, these will provide the pluripotential cells that are considered experimental still, but they hold promise in treating conditions. They reduce inflammation and potentially regenerate cartilage, but research is still lacking in that regard. And we also don't fully understand how platelet-rich plasma works, especially the different preparations we use. And there's lacking clinical evidence in that regard as well. Let's go one step further. What about the Human Genome Project? Well, that's still being decoded, and that's where they're coming up with these quantum mechanic computers. The book of life, as we call it. So if you look at CRISPR, which was innovative in COVID, so if we look at repetitive DNA sequences, in bacteria, there are spaces between those sequences. What if we could harvest those spaces and put in new code that says, regenerate the cartilage, don't degenerate the cartilage? Can we manipulate that in resynthesis? Well, only time will tell, so let's see. And one last thing in prevention, which is very close to my heart. In 2014 in South Africa, we asked a question among, can we screen children? And if we screen them, can we use 50 non-invasive tests? And what implication will this have to the future? So what we did back in 2014 was we took 2 private schools, we just did convenience sampling, and we red flagged kids who had hip pain then. Why did we look at kids? Because we know from about age 12 to 14, their hips are very similar to that of an adult structure, even although their growth plates haven't fused. So we can measure certain angles, which helps. But what was interesting, about 2.5, 3 years later, some of these kiddies started presenting in our practice, and they landed up undergoing surgery. So once we flagged them, we didn't do anything with them. It was a wait and see approach. And we had a 16% positivity rating. And that was pretty scary that it was a 2-year longitudinal study for us. So we did like any good researcher does. We took this data back to our society. We presented it at our annual meetings. And what has it developed? We're now doing an international Delphi consensus study, not a local. We are doing a worldwide with every country Delphi consensus. We're in stage 2 of it. where we are still deciding on the correct age groups and the tests that we're going to use. We are then going to be rolling this out to all the countries so we can test our kiddies, which is going to be around about age 15. Now imagine you can stop your children from having arthritis or having future surgery by modulating different sports that they play. That for me is a legacy moment. And all the youngsters that are here today, the new physiotherapists, this is something we'll be passing on to you to continue with. So I hope you take cognizance of this. So in summary, where are we? So historically, hip problems were often addressed only when total hip replacements were necessary. Modern hip care focused on hip preservation, aiming to treat underlying issues and delay the prevention of the need for total hip replacement. The increase of understanding and technology has seen advancements in imaging, surgical instrumentations, and deep understanding of hip pathomechanics and the physiology, and has led to the development and widespread use of more precise, less invasive procedures and rehabilitation interventions. Future hip care rests with early diagnosis. Identifying those hip conditions earlier will allow for more effective, less invasive treatments before significant damage occurs. Artificial intelligence or machine learning, that is developing to enhance preoperative planning, improve risk assessment, and predict surgical outcomes, and even assist in surgery itself through precision. Regenerative therapy, well, further development is still needed in that regard, and that's through stem cell therapies and other regenerative approaches. Robotic-assisted surgery, well, the integration of robots into hip procedures is now, and it's still improving, so it's still part of the future. But it aims to improve surgical accuracy, reduce complications, and enhance the surgeon's experience. But enough about that. I want to leave you with a wonderful quote from two famous people that I always reference. So it is health that is the real wealth, not the pieces of gold and silver. And giving children a healthier start in life, no matter where they are born or the circumstances of their birth, is a moral obligation of every one of us. Thank you once again for listening to me. Thank you to KLM. It's been an absolute honor being here.
Thanks, Barry. It was an excellent presentation. Really shows your connection around the globe with all of the innovation happening everywhere in the world, but bringing it back here to us and the physio students that are going to be involved in the future non-surgical rehab of hip pain. So thank you very much. Very excellent presentation.
Thank you, sir. It was a wonderful talk and in-depth understanding about the preservation of hip pathology, non-surgical and surgical aspects with respect to latest evidences and methods of treatment available, and more emphasized on the rehabilitation part during non-surgical and surgical also. Before I give my impression, I want to know from the audience if you have any questions to be asked to sir.
Not one question. I can't be that comprehensive. I'm just a physiotherapist like all of you. There have to be at least one question.
Sir, I don't have any question, but I just want to give a feedback on what you have taught us today. So like we know that we can't prevent aging. Aging is a process which is gradual for some people it is fast. It depends upon their lifestyle. So in European countries, they used to have more, they have more of hip pathologies. And in Indians, we have more of the knee pathologies because of our lifestyle, which is gradually changing now. We are going to Western pattern of lifestyle. Not everybody, rural India is still lacking in that. But I have my personal impression that it is always better that whatever osteoarthritis is degeneration, it is not a disease. So as long as you prevent the aggressive treatment like surgery and you delay the progression of arthritis with non-surgical treatment. And if at all in some cases where there is no option other than surgery to maintain or improve the lifestyle, that is the time the surgical part comes. And over and above, you have given the references of the evidence-based Society of Preservation of Physiotherapists is existing. That is a very good idea, and they have given the physiotherapy assessment methods in that. So that is a boon. And then also with the help of artificial intelligence, we can still get more clues how to preserve the hip joint with progression of arthritis. Thank you, sir.
Thank you very much, everyone.
Thank you very much, Perry. I request the chairpersons to present a token of appreciation to Perry. Please present a token of appreciation. Chairpersons can present the token to our speaker.
More on the device finder. Gives me more.
Hello. To chair the next session, I request Dr. Basavraj Nanjanawar to come on the dais. So is Masters of Physiotherapy in Musculoskeletal and Sports from Ramaya College, Medical College, Bangalore. And he's a proud alumnus of BPT from our own KLE Institute of Physiotherapy. He works as assistant professor in charge HOD, Department of Physiotherapy in Belgaum Institute of Medical Sciences. Welcome you, Dr. Nanjanawar. Please take your seat. Our next chairperson is continued by, again, Suzanne Everett, ma'am. And our next speaker is Dr. Deepak Kumar, who is Director and Senior Consultant Physiotherapist, Capri Institute of Manual Therapy. Dr. Deepak Kumar pursued his master's in sports physiotherapy and doctorate in manual therapy with 32 years of vast clinical and teaching experience. Leading a team of more than 100 plus professionals, he is a fellow of IIP and a certified Maconial concept teacher. He's delivered 300 plus workshops, training 16,000 plus physiotherapists across 52 countries. He is also authored the book, which is a bestseller, Manual of Mulligan Concept, which is translated in Korean, Chinese, and Russian languages. So is also a visiting professor at Kelly University and a consultant physiotherapist with Emirates Health Services UA. I think sir did not need this introduction, but sir, it's my privilege to do it. Welcome you, sir.
You can extend it, but you got it. It's the master. May I have big one? Because okay. Thanks. Thank you. Thank you.
Thank you very for the lovely presentation and the great help. Really appreciate. Really, really appreciate. Thank you very much. Okay, so today's presentation is mainly for the private practitioners. And in this presentation, what I'm going to show you a few very interesting studies related to the knee joint. And if you stay in the presentation till the last, I assure you your practice, the way you practice knee joint, it will change for sure. And this will also help you becoming a renowned and highly successful and rich physiotherapist in your city. It's my assurance. So just stay with me. And this is the first study I would share. This is from the South Australia. This paper is as published in the Journal of Orthopedic Sports Medicine. There was a man, this is in February 2018, a man with grade 4 osteoarthritis, aged 66 years, and he was having pain since last 2 years, and he was not even able to walk few steps. So he showed up in the orthopedic clinic, and the orthopedician suggested him total knee replacement. So before total knee replacement, as you know, you have to go for PAC, pre-anesthetic checkup. And in the PAC, it came out like he was having severe blockage of coronary arteries, more than 82%, and he was having very high bone BMI, body mass index, and then he was hypertensive and diabetic. Obviously, he was not a fit candidate for the total knee replacement, so he was refused and he was referred to another department, that is the cardiovascular surgery, and he was advised to go for elective bypass surgery, and he went under that. And obviously, as we all know, after, okay, I didn't put an PPT. Is that okay? Yeah, thank you. Forgot to change. Okay, so he then for the 3 months he went for the cardiac rehabilitation till May 2018, and after that he went for the knee rehabilitation program. And then in the month of September, he received a call from orthopedic department that, okay, your cardiac department, your anesthetic department has cleared all the things, and now you may come for the total knee replacement. And then he said, sorry, I don't need total knee replacement now. And he was able to walk 2 kilometers without pain. And at the time of publication of this article, I have given the reference if you want. After the publication of this article, at the time of publication of this article, that is 2 years after the bypass surgery, that is in 2020, still he was happy, fit and fine, and has not been operated for the total knee replacement. This suggests, and not only suggests, I've seen articles coming up in Times of India, in Delhi edition, as well as in that edition they have mentioned in Britain, they often published news and the articles, and the title of the article is Total Knee Replacement, is it overprescribed? So they say majority of the time orthopedicians are just seeing the x-rays, not going for the Coos score, not going for so many other findings and the functional outcomes of the total knee replacement. They're just interested in increasing their number of surgeries. So probably they are running behind, or they are chasing their world record to enter into Guinness Book of World Record for the total knee replacement. बट उससे नुकसान तो पेशेंट का हो रहा है सारा का सारा. Those who don't need surgeries are getting operated. Sir, when I started practice in 1992, at that time TKR was very, very rare, total knee replacement, very rare in those days. And those days also we were receiving patients of 80 years, 85 years of age, and they were all responding to physiotherapy. So what has happened now? Just because Atalji got operated and everyone now it is quite safe to get operated, that's why you start operating? I don't suggest that. It's absolutely overly prescribed in my opinion, and this is case study clearly shows that not everyone need uh, total knee replacement. And even if you want to go for total knee replacement, TKR, you should, rather you must try proper physiotherapy protocols. See if that is helpful to you. Now, some of you must be wondering, yeah, Deepak, kuch bhi, you're just saying anything. What about if the findings are there in MRI? Okay, look at this. Meniscal tear, it's seen in MRI. Okay, I agree. Yes, it is seen. It's not telling lie. Now what research that data says? In this research, they took 230 knees of 115 uninjured asymptomatic individuals. ना चोट लगी थी, ना कोई दर्द था. कूज स्कोर से चेक किया था. Okay, 115 individual and 230 knees. Out of that, 51 was male and 64 were female, and median age was 44 years. At the age of 60 to 73, 36% people have meniscal tear. Quite a high percentage. Does it mean they should go for arthroscopy surgery or treatment? No, they don't have pain. Okay, then why they should go for surgery? So the MRI findings are overwhelming many times. And same thing is true for the spine also. Binjikji study, you must go through Binjikji et al. For the spine. Absolutely same kind of findings. Like if there is a cartilage defect, I'm sure you can appreciate these two dents here. Okay? And you're wondering, oh my God, if there is a cartilage defect, arthroscopy is the only answer or surgery. See this. At the age of 60 to 73, 62% have cartilage defect. Asymptomatic, uninjured. What about bone marrow lesion? Of course, that makes you scared. The same study says at the age of 60 to 70, 41% people having bone marrow lesion and they are asymptomatic. भाई जब दर्द नहीं है, परेशानी नहीं है, तो क्यों जाऊं मैं डॉक्टर के? And obviously they are not going. But maybe someday, sometime you get injured or you have pain because of some XYZ reason, which is not getting settled with non-steroidal anti-inflammatory or with the physiotherapy or with the rest, and they suggest you MRI. MRI show you this. My God, now what to do? Go for surgery. Maybe it is just an incidental finding in your case. Okay? Now, subchondral cyst. Same study says at the age of 60 to 73, 13% have subchondral cyst. And I'm sure you also might have received many patients who have subchondral cyst and they do recover with proper physiotherapy. They don't go for surgery, either because of some medical reason or financial reason. They don't want to go for surgery. In India, we don't have a very good, strong insurance system. So many times they have to pay from their pocket. So if financially they're not very strong, they don't go for surgery easily. And they do respond to the treatment. They recover. And tell me, during Corona time, people were having all those things, but they were not getting operated. Then how come they became all right? 3-4 years, no surgeries were done. All hospitals were serving only Corona and Corona and Corona. Nobody got TKR, nobody got surgery for those things. How come they recovered? How could they manage without surgeries? And if that time you could manage, why not now? और एक बहुत अच्छी बात बोल के गए थे डॉक्टर केतन बातेकर. Government is talking about don't cut trees. I like that statement. Wow. Don't cut trees, but you can cut humans. Why? Don't cut humans also. If it is at least, if it is not required, try to heal them with the help of natural way. That was a meta-analysis. And in this, they included 63 studies, meta-analysis, where they had 5,397 needs of 4,751 individuals. And the outcome is almost the same what I showed you in the previous study. That means if your knee MRI says something is scary, don't be afraid. Everything is okay. You can still try with the physiotherapy. And physiotherapy friends, please don't be afraid. Don't get carried away with the impression, oh my God, ye to dikh raha hai samne samne. It's there in MRI, it's there in X-ray. What can I do now? Surgery is the only answer. No, don't worry. Nothing. And here I remember this beautiful song by in Three Idiots. One second. Okay? May tell your patient, don't worry. All is well. Okay? No need to get afraid after seeing the MRI findings. So if you know these things, I'm sure this will change your way you communicate with your patient, way you talk with your patients, way you treat your patient, and majority of the time when young physios give up, that findings are there. Okay. Now another important thing. What about the joint space of the reading? Okay. That is called parallax error. I don't know why we clinicians are not. If you just take the axis slide, this is from the spine, okay? The space is same in all the discs. There is small space. 5 degree, this is the 0 degree, you can clearly see the disc space. However, in reality, space is same in all the photographs. But depending from where you have taken that X-ray, how you have shooted that X-ray, it all depends. So in knee joint also, if X-ray is slightly up, hardly 5 degrees, that is nothing. You will not see good joint space. And if you don't see good joint space, you say, my God, joint space is not there. Surgery is the answer. Please go for surgery. I can't help you much. And there are few masoom. I would say I don't call duffer or stupid people. I prefer to call masoom. That's more polite and polished word. There are few masoom physios. उनके पास सर पेशेंट आते हैं एक्सरे गलती से गलत एक्सरे if that is a wrong x-ray they do that and after that they do the therapy and after therapy maybe patient out of curiosity because if patient is feeling better patient go for a new x-ray and if new x-ray is taken properly wow Instagram की तो रील बन गई before and after physiotherapy से हमने we increase the joint space with the help of physiotherapy impossible you cannot increase the joint space and that's why I'm calling you मासूम physio तुमको पता ही नहीं है कि तुमको क्या नहीं पता है you cannot people are laughing at you when you publish that earlier there was no joint space after my therapy there is a joint space they say excuse me earlier x-ray was not taken at a proper angle now x-ray is taken at a proper angle and that's why you are able to see the joint space very simple very easy okay so make sure when your patient comes your patient don't have parallax error so you don't get fooled by radiographer okay now I have to make you people understand I have recorded one video in this I put a glass in the bottom and on the top and I'm going to change the angle of my camera and as I'm changing the angle of my camera you will see the joint space is getting reduced and increased so that you understand better so this is what I shooted at my home with the camera there okay and this is the real space but if I'm taking my camera up and down you will see this space reducing and increasing however you will understand the space is still the same I'm not touching those two glasses see now if I'm taking it up camera is going up and it is now you see the space is getting reduced and you don't see much space now in the knee joint imagine it's a knee joint okay and then space is there now space is again not there so it all depends what angle they have shooted so don't get fooled with the parallax error make sure you watch that another study very interesting study why the patient do get knee pain in this study what they did a arthroscope and in the knee joint they give a air pressure and it is the surgeon who did him on himself he himself was a model and he did that and then when he was giving irritating different structures he graded the pain okay how much pain he's feeling so maximum pain he felt when he was irritating the fat pad the black one area that suggests it is the fat pad which is highly innervated most innervated structure and when your patient comes with the help of McConnell taping from Western Australia, Jenny McConnell, she's a friend of mine. So if you do those McConnell taping and offload the fat pad, pain goes off like this immediately, no matter how severe the pain is. And before doing that McConnell taping, maybe you can put your hand on top and on the bottom and lift entire thing up. And then ask patient do the isometric contraction. And if patient is complaining no pain, immediately no pain, then where the osteoarthritis has gone. You have not done for anything for the osteoarthritis. You have only offloaded the fat pad. So if patient says better, okay, of course, do the taping, do the offloading, and patient will be fine. We do treat patient those who cannot go or don't want to go for surgery. We offload their fat pad. We do physiotherapy. We do the strengthening of the gluteus maximus and the medius and the hamstring and the calf and the psoas muscle stretching, quadriceps stretching, vastus medialis stretching, strengthening and stretching. All those things do help patient, and they have been responding beautifully. Okay, so now I'm going to show you. Okay, I've been allotted 30 minutes, so I still have 15 minutes with me. So I'll show you a few techniques of manual therapy. If you use these techniques, patient will recover in a magical way, in a beautiful way. Okay, but I hope you understand the previous studies. In summary, don't get scared with the MRI. It's okay to have those findings. Nothing wrong in that. It's very, very common finding, and might be in that particular patient, it could be just an incidental finding. Remember the parallax error. Don't get fooled if the X-ray is not taken at a perfect angle. And that's true for the spine also. Okay, so in case patient comes and they are having pain and you are interested, in addition to the strengthening exercise and electrotherapy, you want to do some manual therapy also. So I'm going to show you a few manual therapy techniques here. You may try those to help your patient. So stabilize the tibia with one hand and the other hand goes behind. So in this case, if patient is having pain on the lateral side of the knee joint, I recommend to mobilize the superior tibiofibular joint. This pain especially comes after the patient is having ankle sprain. So positional fault not only takes place at the inferior tibiofibular joint, but sometimes maybe at the superior tibiofibular joint also. So how to mobilize superior tibiofibular joint? Sorry. So stabilize the tibia with one hand and the other hand goes behind. And then you do the passive accessory movement. In
Red
case
arrow
you want to
is the
sustain the
stabilization,
glide
green arrow is the
and want
mobilization.
patient to move it. So I will sustain the glide and now I will ask him to extend his knee and then back. So I'm sustaining my glide and asking patient to do it and sustaining my glide.
Okay, this is how you mobilize the superior tibiofibular
So
joint.
stabilize.
Now, in case patient is having hand range flexion restriction, I recommend, as per biomechanics, I will recommend to do the posterior glide, and this is how you can do the posterior glide to the patient.
You will also need a belt to wrap around the ankle of the patient. So I will make a figure of 8 around the ankle of the patient and then lock it there and then give it in the hand of patient, which he can pull comfortably. So I take it in the hand range and then I put heel of my hand on the tibial tuberosity. With one hand, I'm going to stabilize the femur and the other hand is going on the tibial tuberosity of the tibia. And this is how the treatment plane is. So where my forearm angle will be, absolutely in the same way. So I'm going to put my forearm angle like that. And when he's going to bend the knee, the treatment plane will change from this angle to this angle. So giving that glide and then asking patient to bend the knee if it is comfortable.
Why you should change the angle? Because you want to follow the treatment
See
plane.
my forearm angle, it's gone down. Now extend your knee and my forearm angle is changed. Again, bend your knee and I'm sustaining my glide. You will also need a belt to.
Now, in case, and I'm sure you will agree, many times when patient above 60 years comes, you will get some fixed flexion deformity, maybe 5 degree or small one. And it's not easy to gain that full range. And until unless you correct that fixed flexion deformity, the rubbing of patella will not go away. And if the rubbing of patella will not go away, the fat pad irritation will not go away. So it is mandatory to correct the fixed flexion deformity, and this is the technique will help you in treating the fixed flexion deformity.
So you want to do the anterior glide. One hand goes just behind the tibia and one hand goes just in front of the femur. Now, make sure when you're putting your hand on the femur, your hand is not on the patella. It has to be above patella, otherwise you may compress it and produce fat pad irritation. So go there and then give the anterior glide and do the oscillation.
But in case your patient is quite big and you are a papa ki pari, choti si pari, so jiska haath chota sa hai, so you can use the belt to treat the same.
So I put the belt
This is
there.
going to be more aggressive
Again,
now
make
because
sure
you're
it
using
is
the
close
belt
to
now.
joint line. The belt goes there and you're looking towards the face of the patient.
So
So the
as per
belt form is
biomechanics, you are
straight.
doing the anterior
Because
glide
this
now.
is the anterior glide you are doing, and your shoulder should come on the knee joint there, so that you are doing just the anterior glide. Now stabilize with the hand, and with the belt you can give the necessary movement.
Okay, and that doesn't work sometimes. You may have to do the
So check the angle, give the glide, and then push it down, and then back, and then push it down, and then back, and then push it down. Now, in case it is not working, if it is still giving pain, you want to change the angle. Now it is anterior lateral glide, and you can do the same thing, or more lateral as compared to anterior. So find out which angle is working on the patient.
and this technique is my favorite technique. This will also help you in treating the internal dearrangement of the knee joint, internal dearrangement. Okay, so
Your friend can grab it strongly, and then you go to the just above the ankle joint, grab the medial and lateral malleus and give a traction to the knee joint. So along with the traction, you can go for the internal rotation. While maintaining the internal rotation, you can go for flexion or back to 90 degree. Flexion or back to 90 degree. Or if you can reduce the height of the plinth, then you can also go for full extension. In that case, I will go for the traction again, and then the internal rotation, and go for the extension. Now, because the height of the table, I'm not able to go full into extension, but if the height was less, I could easily achieve good extension like that. I'm sustaining my glide.
So in this technique, what I'm doing is I'm giving traction to the tibiofemoral joint, and along with traction, I'm doing the internal rotation, and along with traction and internal rotation, I'm doing passively flexion and extension. This helps the patient in a magical way. I yet to see a patient in my 33 years of practice, yet to see a patient who has not responded to this technique. Yes, maybe some patients respond temporarily because the changes are so many and there are so many other problems, but still they have responded. So if you can remember only even the last technique only, and you treat your patient and remember those studies where everything is okay, even if those findings are there, it's worth trying. I always tell my students, if it is not contraindicated, it is indicated. It is worth trying. And if you have studied orthopedics properly, remember any neuromusculoskeletal mechanical pain, if can be provoked, will be provoked either by maximum compression or by maximum stretch. So if the movements are increasing or decreasing the pain, means your therapy will help. If movements are making no difference, patient is constantly having pain, your movements are neither increasing nor decreasing, okay, I agree, maybe he is not your patient, maybe he should go for medical management. But if movements are either increasing or decreasing pain, he is your patient. It is worth trying. If it is not contraindicated, it is indicated. And don't be afraid of seeing the MRI findings or the X-ray findings. They are okay, they are natural, they are present in everybody's body, and it might be just the incidental finding. So again, once again, the same song for you and for your patient. Thank you very much. Thank you for your time.
I hope this will help you in increasing your private practice and you will stop refusing patients after seeing the MRI or X-ray and you will try to treat the patient first. Thank you. Thank you so much.
Thank you, Deepak Kumar sir.
Thank you, sir.
Indeed, it was an eye-opener for everybody. And well, right now, I think they'll be in a position which one to choose and which one to not to treat a knee more effectively than before. Wonderful, sir. Thank you.
Thank you, sir. Thank you very much.
Thanks, Dr. Kumar. I work in a multidisciplinary clinic in Adelaide in Australia where surgeons and physios and doctors and podiatrists and everybody are all together. And it's very gratifying to hear you talk about this trend to try exercise, try everything else before going to arthroplasty. And do you have the GLAD program here?
This case was from the GLAD program.
Yeah.
The first case I showed was from the GLAD program.
Yeah, and that's got some really great evidence. So it's nice to hear this. It's surgeons sometimes aren't happy. The sales of expensive cars might go down. But I congratulate you on this presentation. So thank you very much.
Thank you. Thank you, madam. Thank you.
Any questions from the audience?
Sir. Sure. Okay. Yes, please, please. What, Mike?
All connected.
ऊपर से आके बोल.
Hello. There was a study in PGM Chandigarh. we took 40 patients already advised for PKR, and in combination with community medicine, we have done that study. All patient has been taken from orthopedics department and advised PKR. And after the complete rehabilitation, out of 40, 22 has been already cancelled the TKR. And there was a big tussle. Then it was published in the paper, and there was, after that, there was a big tussle between me and the orthopedician. Why? How scientifically study you have done? It is up to you how you have taken it. ये हमारा responsibilities नहीं है, patient और आपके तरफ से आया है, जरूरत नहीं है. तो हमारा study fruitful है. There was another positive study, of course, not a study, my experience, my own patient. I went to orthopedics department for my mother's problem. And I have seen one patient is sitting over there. She was also my patient. Sorry. So, Dr. Saab पूछ रहे, how are you now? Patient मुझे नहीं देख रहा है. I was standing behind the patient. Doctor asked that patient, how are you now? I am better. तो आपका TKR नहीं चाहिए. Private में उसको बोला गया था TKR चाहिए. तो then she was very happy. उस patient को पता नहीं उसके पीछे मैं खड़ा हूँ. तो उन्होंने बताया ये पीछे जो है आपका ट्रीटमेंट किया क्या? तब देखा है बोल रहा है ये he was my doctor. So this has been done more and more number of patient. आपके स्टडी देख के मुझे वो याद आ गया, इतना हम लोग भी किया है. तो juniors has to take the education on the basis of that, and confidently you have done the all is well. Thank you.
Orthopedician, they purposely don't decide patients to the surface. And when you say, hey, this was our case, you have to fix it. And I know what they're thinking inside. I even which they have a pressure of the corporate world. They have to operate this number of patients per week and per month. They have to. Otherwise, they'll be thrown out of the hospital. And they know if they refer patients to the physiotherapist will treat it so well and their practice will go down. That's a different story. But my idea was not to expose those. My idea is not to
mic set ಕೊಡ್ಲಿಲ್ಲ.
We try at least 4 to 6 weeks time, and we also, it's not only the therapy, we need to also check their expectation, how much they are expecting. If their expectation is just move around, do their daily lifestyle, and that, okay, done. But if their expectation is high and they're not responding to the physiotherapy, they should be honestly so they have to go. Physical treatment program is
Hello. Thank you, Deepak sir. I request the chairpersons to kindly present the memento and certificate to Deepak Kumar sir. I request Dr. Anand to please felicitate our chairpersons. Our next session chairperson is Professor Dr. M. Vijay Kumar, who is Professor, Sports Physiotherapy and Rehabilitation, Modern College of Physiotherapy, Pune. Sir is a distinguished academician, clinician, and researcher with over 25 years of excellence in sports physiotherapy and rehabilitation. Sir holds multiple national and international qualification, including the FTSR London UNESCO certification in bioethics and human rights. He has published 41 international research papers, has authored 5 books, and holds 1 granted patent. Sir is a dynamic speaker, mentor, resource person at various conferences, and has also organized 3 national and 32 specialized workshops. So we welcome you. Our next chairperson for the session is our very own Dr. Anand Heganawar, who is Professor HOD Orthopedic Manual Therapy at Kahir Institute. He has 15 years of academic and clinical experience and has published 66 peer-reviewed research work in indexed journal. He has delivered 12 research papers at various national and international forums at Amsterdam, Singapore, Geneva, Dubai, and Bali. He's attended many national international workshops and even 33 professional workshops. His administrative post is that he is assistant controller of examination at Kahir University. Welcome you, Dr. Anand. And our next speaker is Dr. Asha Menon, ma'am, who heads the Department of Mackenzie Clinic, Arogya Nidhi Hospital, Juhu, Mumbai. She's a retired senior faculty. Madam has 36 years in clinical work and 22 years of using Mackenzie method. She is foundation of teaching and learn for learning planning for teaching and learning Commonwealth Education Trust. She uses instructional methods in medical education at Michigan University. Madam is a retired senior faculty for Mackenzie Institute International and has been awarded the Academic Achievement Award for significant contribution in the field of physiotherapy. Welcome you, ma'am. Off to you.
I put my hand, so I sent to 6:19. Is it okay? That's it. Yeah. Fun. Yeah, perfect. Caller mic ಇವಾಗ ಬ್ಯಾಟ್ರಿ ಇಟ್ಟಿಲ್ಲ ಗೊತ್ತಿಲ್ಲ ಕಾಲರ್ ಮೈಕ್ ಐತೆ ಅಂತ ಕೇಳ ಕಾಲೇಜ್ನಾಗ
Hello.
should take care, no?
So I have 20 minutes, half an hour. All right. So 5 or 25. So thank you so much, Principal Sir, Dr. Santosh Medkut, Dr. Anand Hegenauer, Dr. Ganesh, and the entire KLE University, and all those who are there behind this conference for the invite and for a lovely conference which has been organized so well. So let's start with our, before we waste any more time. All right. So I'm talking on McKinsey method, a model for tech-enabled rehab in chronic low back pain management. All right. So we have seen a lot of tech-enabled rehab, and we've seen remote rehabilitations happening post-COVID. And we have a lot more researches happening. We also have seen that there are people who are specialized into remote rehab now. They are doing only remote rehab. So there are companies that have come up which specialize in remote rehab. So let's see how the McKinsey method does it work with tech-enabled rehab. We know chronic low back pain, it affects the quality of life and the functional capacity. The main reason is because the chronicity is not only in the time. Chronicity also, we are going to see in this chronic low back pain population of patients, you are going to be seeing a lot of drivers of pain and disability. And so the functional disabilities that happen with with this population of patients due to the drivers of pain will make a lot of problem with giving good outcome scores in patients in this population. So what we need to see here is that we know that many of the studies have suggested that passive methods of treatment should not be given to chronic low back pain. All right, because of the drivers that are there, passive is only going to make it more difficult for us to get good outcomes. So they say, okay, let's give exercise. And exercise is more of an active method. But what happens with exercise is that you see that the traditional exercise-based treatments, they are active, but patients tend to fall back on it. They have either forgotten half the exercise you prescribed, or they do not want to do it. So there is poor patient adherence, and there is also a limited accessibility. Sorry. Right. So MDT, mechanical diagnosis and therapy, which is also another way that we call the McKinsey method. It is suitable for remote management. The cost effectiveness of the McKinsey method is already proven. So it has been proven that although, because the McKinsey therapists have got an added qualification, so the maybe the cost per session may be high. But if you are going to see the self-management and patient empowerment, that is a philosophy of the McKenzie method. So you see that overall, for a patient where chronic low back pain is an episodic disorder, you will find that patients do not need recurrent healthcare costs for managing this. So on the long run, if you go to see, it is cost effective. Also, we see that you do not find a lot of McKenzie therapists everywhere. At least in India, they are very few. So what happens is if there are areas where a McKenzie therapist is not available, you will find that when you are going to use remote methods, uh, the system is available to those who may be living in areas where there is no McKenzie trained therapist. So we can also use the assessment system is very different, which is what I'm going to be saying on the next few slides. It allows remote assessments using videos. So the patient can know what to expect. So we could send a video across for them to know what to expect. And it also supports real-time feedback. It's just like a face-to-face. We could do it on whatever platform that you may use, whether it's a web portal, whether it's a Zoom or whatever portal you're going to be using, you can do just like a face-to-face. You can give feedbacks to the patient. So when you're looking at chronic low back pain, does just definition in time describe the reality? No, we do need a biopsychosocial model here. Waddell has very rightly said that those patients who respect or who accept the responsibility for their treatment will do better and their outcomes will be better. And so in these patients, we need to have a very active form of examination and an active form of management where the patient is a very active participant. So does MDT recognize a biopsychosocial model, which is very important when you're looking at chronic low back pain? And can tech-enabled rehab be a reality using MDT? Let's look further. So it does incorporate biopsychosocial model. Now, how does it? We have active patient involvements at every level. When you are going to take a history taking, it's patient reported. It is open-ended questions where the patient is actively participating. And there are times where a patient has said, nobody has really heard me till now. So it's a very active where the patient and the clinician is actively uh, taking part in the conversation and the patient is heard. Also, when we are going to be doing repeated movement testing, which is a method of examination of a patient, where we would not do the examination in terms of looking at aberrant movements of the spine or palpation. It's more of movements, active movements, which are tested out repeatedly. This will help the patient to counter the fear. So if he fears movement and if you are flexing him and he expects that the pain is going to increase, but probably the patient is not going to increase with pain if he's going to repeat the flexion many times. And if that's the case, he knows, oh, I expected my pain would hit the rooftop, but it's not. So you are countering the fear, you're countering the distress that he has. You are also countering the various other coping strategies or the depression, somatization. All these things are also being countered by the repeated movement test. When we are asking a patient to do repeated movement test, we are also going to educate them. They should know what to expect in the examination. So when we are going to be educating them using various educational methods, looking at their stage of learning. What is stage of learning? I know I've got pain, but why should I do this movement? I've been told not to do this movement. Why should I sit straight? There are people who have been sitting in a stoop posture for years together and nothing happens to them. So why should I do that? So they're not prepared to change. Their stage of learning is where they are not prepared to change. We need, with our education, to get them from that I am not ready to change to maybe I need to change. So you come from a pre-contemplator to the contemplation. And then you're going to think of, okay, I think I've started to change. I am going to change. So you counter education. When you do, when these are the methods in which you're going to examine the patient, there is going to be an active patient empowerment and patient self-management. So when you have told the patient, when you have shown the patient that one particular movement, we know 78 to 80% of patients can have directional pains. If you have shown the patient that movement is good, and when you have moved, you have actively participated in your life rather than being a passive person taking prolonged bed rest, and you have showed that one movement that you have done or just sitting uprightly has decreased your symptoms, he's going to actively take part in the process of management. And every next time when the pain is there, he knows he's got to sit up straight to get his pain eased. So there's a self-management that is coming, or he does the exercise and reduces it. So these would counter the drivers of pain and disability. What about the interaction of various pain drivers? We do recognize that nociceptive, which is a referred pain, neuropathic, which is a radicular pain, and the nociplastic, which is the processing of pain that is there. All these three, we recognize that they can be inherently there in the same patient in a chronic low back pain. And so there are different things that's needed to be done in these patients. If there is a nociplastic pain, the patient will require more support than just physical therapy. So also education will be handled in this way, which can easily be done face to face. Let's look at orthopedic special tests now. What is the difficulty when you're assessing a patient remotely? Some of the examination that we do may not be possible in a remote method of assessment, and orthopedic special test is one of them. We know there's a high rate of false positive and false negative in an orthopedic test. All of us have seen patients where an orthopedic test has been done in a patient. The orthopedic surgeon says, "Oh, you need a scopic surgery there," and he comes to us, and we might find that test is positive, but we do physical therapy, we give the exercises, and we see that the test turns negative, right? So that's the false positive and false negative. What we do as a McKenzie clinician, what I would be doing is, there are some orthopedic tests that we cannot do remotely, but there are some orthopedic tests that we can do remotely. So what we would do is, I would take the symptomatic baselines of a patient, do the baselines, which is the ranges, and I would also see the orthopedic special tests. And then I am going to be during, that is before testing, all these baselines are taken, and then I would do a repeated test of every movement. And after I do a repeated test of every movement, if it's chronic low back pain, flexion, extension, maybe the glides, so I would do repeated tests of the movements that I've decided to do from the history. And then during testing, I would see what's happening to the symptoms. After testing, once again, these baseline tests that I did of the symptoms, the mechanics, that is the ranges, and the orthopedic special tests, these would be repeated. So if any particular movement has made that orthopedic special test go negative, which was positive before the repeated test, we know that that movement can be beneficial to the patient. And more importantly, we are doing remotely, but yet the patient has seen, oh, this was positive for me, but now I don't have pain and I can easily do it. So they know that the test has got negative. And so it empowers them that, yes, this movement is not going to be harmful for me because I've got better. And this also gets them empowered to carry out the movements and counter the fear. So let's look at what are the other challenges that are there. Okay. So clinical interpretation of history and examination, the patient can just go on and on. First of all, in many of the times, chronic low back pain patient, there is a huge disparity between what the patient is telling us, the functional disability he's telling us, and when we are checking out, there is a huge clinical disparity. We feel that the patient is not as bad as he shows himself out to be, right? And so that's the same thing. So the history and the clinical examination does not match. So what we do is, we know the symptoms that the patient is saying cannot be relied upon. What would we do is, the same way we take the baselines, we take symptomatic baselines, okay, but we know we can't rely on them. But in addition to it, we see all the ranges before, and after. And during the movement testing, we ask them what's happening to the symptoms. And we know for sure that because of the pain chronicity, we might not get a true picture with the symptoms. But if you're not getting a true picture with the symptoms, we have another backup plan there. And that is, if one particular movement has, repeating one particular movement has changed his baseline test of, let's say, going up and down the stairs, or a squat, or his orthopedic special tests, or his movement ranges has improved. So he was able to flex up to the knee, and now he can flex up to the ankle. So you know the ranges have changed. That would be where you know that that particular movement will be beneficial, which can easily be seen by anybody on the face-to-face, or if it is remote. Now, it's very easy for us to know what is directional preference. Very simple. Directional preference is where one movement will, if you're repeating that, you will get decrease in the symptoms, increase in the ranges, increase in the functions, and even the orthopedic special test may go negative. Okay, so so that means that the opposite movement is going to give just the opposite reaction. That means the opposite movement is going to increase the symptoms, decrease the ranges, and decrease the functions. All right. So let's look at how we would do it on a chart. MDT assessment identifies barriers to recovery. Once we know what the barriers are, if there are high barriers, we know we'll have to rely more on the mechanics and functional tests. The patient may have a directional preference or may not have a directional preference. So if he has a directional preference, that means that one movement is making that patient better. We will know what specific education has to be given to the patient. That's going to motivate the patient, give specific patient education. And this is a population of patient who is going to respond fast. But again, if you have multiple drivers in that patient, then that patient is going to respond a little bit, he will take a little longer time as compared to the patients without drivers. Okay? Let's say if a patient has got directional preference, let's say the patient has got no directional preference, then once again, you have not identified one movement that will make him better. So you've got to go with evidence-based management, which will be a functional training. He might need cognitive behavioral therapy. Okay, he will need multidisciplinary treatment, probably also may need to be referred to a psychiatrist. Once again, in this patient also, there will be an individual patient education which is done. These are going to be slow responders. Let's look at challenges once more in the management. Now, most of us, all of us as physiotherapists, we have to use hands-on. How do we use hands-on? In remote rehab. That's the biggest challenge that all of us have. Now, for us, it becomes a little bit easier because we have a progression of forces. What do you mean by progression of forces? That means first the patient does the movement, repeats it over time. The patient exhausts his forces, so he does patient overpressure, and then the patient moves and the clinician gives overpressure. Okay, so and then comes a mobilization and then the manipulation. So there's a progression of forces. So here what we can do is we can exhaust the patient forces and we can use other methods in which you can use an end range. So different ways to reach an end range can be done. Okay, so here this is what I was just talking to Dr. Deepak Kumar earlier during lunchtime, and I told him that, I believe that, McKenzie, Mulligan, Maitland, they all say the same thing. What do they say? They say reach the end range. So you might use a McKenzie concept, you might use directional preference. But if I need to use a directional preference, one movement, and I need to do clinician forces, and if I'm not able to do, I might, using the McKenzie method, I might think in terms of, MWMs. I might think in terms of different other ways. I might try to use Maitland, asking the patient to do, palpation and maybe using the camera and then asking him to mobilize himself, getting to understand the ranges, the symptoms, keeping a baseline. So you should be globally, you should be able to adapt yourself when you're doing a remote assessment and management. So we can have different ways to reach an end range. So if you want to use a different way to reach an end range in the lumbar spine, we know spine moves as one. So if you want to increase the range in the lumbar spine, increase the range in the entire spine. So if there is any flexibility issue in the rest of the spine, release that too. You are going to get a greater range in the lumbar spine and the reduction of the symptoms. So different ways you've got to try and get into an end range. Also, there's a one exercise versus multiple exercise. So in the McKenzie method, by and far, about 78 to 80% of the patients, we would use one exercise. When it is one exercise, it takes about a minute to perform, and the patient will not forget the exercise. He will not say, "Oh, I'm lazy to do the exercise." All we need to ask is, "Does it take a lot of time?" Okay. Again, videos of exercise prescribed. So you can send the patient off with the video. So it's only just one exercise and he's done it himself and you're taking the video on him. So he cannot say that, "Oh, I forgot it," or "I forgot the technique," or that he does wrong and comes back and the session is wasted. That also, it can happen, but the percentage of it becomes much lesser. So enhancing adherence can be with education, and as I said, patient can be in a pre-contemplation stage where they're not ready to change. So it is we are the clinicians. We are the ones who have got to teach them and educate them how they have got to adhere to their exercise regime. And if they don't follow it, it's not like तुम नहीं करते हो, तुमने exercise नहीं किया. No, did you educate him enough for him to understand that he needs to do the exercise? So the fault lies where? The fault lies with us. We are the ones who has got to tell them why it's important for them to do it. So we need to educate them looking at their stage. Are they in a preparatory stage? No, I don't want to change. I don't think exercises are going to help. So you got to show them, get them from that pre-contemplation stage to a contemplation stage where, okay, they're ready to start thinking about the exercise or ready for a change. And then they're in the preparatory stage where they've started doing the exercises, started taking care of the postures, and then they're fully into it, compliant 100%, and they're maintaining it. That is when you have discharged the patient also, they know that the chronic low back pain is an episodic disorder. And so it's going to come back. So the first thing you're going to say at discharge is, well, mehman wapas aane wala hai. So you are the one who is responsible to see to it that episodes do not occur very, very regularly. Another is a scheduling software or AI reminders. Okay, so these are things which we can also use to get them to do the exercises. Otherwise, they can just put a reminder on their phone. That's also easy. Personalized support with technology. This is very important because when you've seen a patient, all that you need to do is get them to problem solve. Do not babysit them. So if they say ki pain बढ़ गया, my pain has hit the rooftop. Okay, so don't give them answers. Say, when did it happen? What were you doing? What position, postures, activity were you in? So let them give you the answers. Okay, because they have to be actively involved in this. They are the one who is the architect of that pain now. So what were you doing? What did you do to reduce the pain? Did you do the exercises? Did you sit in the right posture and do your work? No. So did you do it? Can you do it and see? So get them to come to the conclusion as to why their pain increased and what they need to do. Let them problem solve. Also, so give them quick replies there and don't give them the answer. Let them come to the answer themselves. Also, active involvement in self. So when you do this, what happens is there's a very active involvement on their part and they know that they are responsible. So the first thing I tell them is you are an architect of your pain. So who has got to take care of it? You are the one. All right. So there has to be an active self-management. This can be done whether it's face-to-face or on remote. It's absolutely can be done in the similar way. So cognitive drivers affecting the outcomes in the chronic low back pain. All these things about the beliefs, the expectations, catastrophization, fear, perception of illness, illness behavior, low efficacy, all these things are easily seen and we have got to identify them on history. And these have to be countered, and this can be countered either ways, online or offline. Okay, so we need to use also, we what we normally do is, when I do an online session, also use auto reply solutions, give them auto reply solutions, give them, give them, okay, you do the exercise and you send it to me and you tell them whether they're doing it rightly, what are the mistake that's happened there. So do not give them the reply directly, let them find out things. You also have ready-made videos that you can give it to them so they can compare it with what they are doing. That's another thing that you can do. Also, you can give feedbacks about what they are doing. Okay, very good, excellent, you have countered your pain yourself, you have done a good job about your pain. When you're going to congratulate them on that, it is all remote, you might reply to them 2 hours later, not immediately, because it's all remote, but it goes a long way in building the confidence of the patient. Okay, and these are very crucial for empowering us and getting the patient to self manage. So what's the challenges here? The challenges are there's limited research. The world is only boomed now post COVID in terms of online. So there's still a lot of research needed to be done on various methods of examination, various methods of management, and also what are the different, if you're going to be using functional rehab, what would be the outcomes? If you're using just the McKenzie method, what would be the management? What would be, if with a directional preference, what would be the outcomes? Everything has to be seen. If it's general exercises, what would be the outcomes? So there is very limited research yet. Also, there are technology gaps. And another big is low acceptance among some people who may not be very techno savvy. And seniors are not very willing to do. So I've yet to come across where seniors are ready to do it, although one or two of them I've had who has been my online client. Uh, but that's a big challenge. So that's about it. I think, Anand, I've finished it on time. Yeah, any questions? I'm willing to answer.
Audience. So that was so nice from you, ma'am. Really, it was good to hear from you about the biopsychosocial model that's been recently emerging in chronic low back pains and how your MDT is helping you up. Thanks for giving insights on the false positive and false negative result that usually is being misunderstood and mistaken for taking up assessments and managements. Your directional preferences is something that people have to understand, that like you always have to get them into depending upon directional preferences. And thanks for giving insights on the challenges on MDTs and its management. So there's a nice wrap up and there's nice information given to most of us. So people who are actually getting into manual therapy, into AA-based systems of therapeutic systems, this will be a better, it will be good information of how to go ahead and how not to go ahead. Nicely spoken up. Thank you very much for your time and your session.
Thank you, ma'am, for that insightful lecture. I request our chairpersons to do the honors. I We continue with Dr. Anand being the chairperson for the next session as well. I request Dr. Girish Meti sir to chair the session. So is our very own alumnus. So is a leading physiotherapist, a private practitioner in Bagalkot, and our very own alumnus. Welcome, Dr. Girish Meti. I request Dr. Rinkle Malani to chair the next session along with Dr. Meti. Ma'am is a director, professor, MGM School of Physiotherapy. Madam has chaired many sessions and has been a resource person at many national and international forums. And she expertises in workshop on biopsychosocial framework, pain science, education and assessment of non-organic science in chronic musculoskeletal pain. And we welcome you. And our next speaker is Dr. M. Vijay Kumar, Professor, Sports Physiotherapy and Rehabilitation. So welcome you.
Thank you. So sometimes, and as you all know, the tail comes last. So finish with the heads. Barry has done his job, Deepak sir has done his job, Asha has done his job. And last, the tail comes down to wag a little bit to find that it also has a place to move around. So I'm following your footsteps, boss. Thank you very much. Right. For today's presentation is on imbalance in reciprocal firing mechanisms of muscles, which is a potential cause of injuries in sports. Based on my experiences working in clinical setups, based on experience on working in sports sectors, we always find that usually injuries do happen of multiple causes. A lot of things are being addressed, like you have your intrinsic factors, extrinsic factors, blah, and we all know this. All these injuries, they happen, and everything's absolutely unexpected. We just don't say that your injuries. This is working. Which one is this? Can I? Yeah, fine. Thank you. So we all know injuries don't tell you that I'm going to come down to get your hams injured or probably your knees injured. They come unexpected, absolutely. You just don't know whether you're going to have your head injured or your knee injured or ankle injured or your shoulders injured, but it gets injured. That's a fact of sports. But when you come down to injuries, the most commonest things that we look at, a lot of factors that is being described in researchers, evidence that says that there is no one single factor that can be said that this is the major cause for injury. But however, most of them accept that biomechanical factor is one of the most commonest factors of injuries. And among the biomechanical factors, they always find that your intrinsic happens to be the most commonest and the most leading component of it. Of course, yes, true. You may have a lot of problems with your footwears, your grounds, your stuffs, but injuries happening because of intrinsic factors are highly more, and they're actually preventable. Because if you're good, if your muscles are good, if your systems are good, if your working is good, if your training is good, of course you can prevent your injuries. But probably because you have no control probably on the grounds, on the climates or probably on something else, which is not under control. So intrinsic factors happens to the most commonest, so we all know about it. Among the intrinsic factors, we know that could be overuse injuries, it's all known, your poor techniques, inadequate warm-ups, your ill-fitting equipments. But however, which usually is found that on the field where something is going down wrong is usually probably because of an ill-conditioned sportsman and probably doesn't have an adequate rest. Because you may have a good warm up, okay, you may have a good strength, you may have everything, but if you're not being conditioned well for the particular sport, for the particular activity, for the particular event that's going to happen for you, if your muscle is not being conditioned for its own coordination or for probably for the amount of force to be produced, of course injuries are more prone to be happening over there, and you land on the multiple injuries from strains to ankle injuries to your ACLs. You have a lot of injuries that happens over there. It usually happens because there is a improper condition that the sportsman usually is actually is on, because every sportsman is trained. He goes for a strengthening program, he goes for his mobility program, he goes for a stretching program, he goes for his agility, whatever you know, he does one, and they also go in for your sports physical training programs. But is a training is equal to a conditioning for the requirement of the sports? The answer is definitely no. It's absolutely different. Okay, so when you have so many injuries, in the experience you could find that what could be the major causes? Because when you say sports is usually a high velocity in activity. You just can't say that what time I'm going to run, when I'm going to run, when I'm going to turn, when I'm going to jump, when I'm going to do an activity. It's absolutely is unpredicted, and you just can't say that I'm going to do this activity as of now. And more than that, okay, you have to have speed as a criteria at some times. So when this high velocity is a demand of a sports, you definitely need to have a fantastic balance on your strength, a fantastic balance on the length of your muscles, and most importantly, you should be having a perfect neural activation between your antagonist and agonistic muscles. That's very, very important. But how and why? Because we all know, as per the basic physiology, that there is an antagonistic agonistic innervative component, that whenever your agonistic muscles work, your antagonist is must relax. It could be either relaxation or release. Because when you have a strong antagonistic muscle that is working on eccentric component, only you'll be able to have a controlled movement. Otherwise, if you have only a concentric movement of an agonistic muscle, if antagonist is not actually working eccentrically, you either have no activity or you don't have probably a balance in your activities. So you need to have a balance. That is, there should be a contraction and the release of the antagonistic, not that the antagonistic muscles doesn't work at all. So this release is a controlled mechanism of your muscle work. We call them as eccentric work. That's all known to us. Right. So why is this balance of reciprocal firing is needed? Is because balance in the firing of impulses with required volume. So how much amount of force is required for your quads to contract? You need to have so much amount of muscle to be working at the hamstrings to slowly eccentrically release for a controlled action of a quadriceps. If your quadriceps is working, for example, if your hamstring is not releasing equal to a hamstring in terms of speed by providing his contractions, probably you may have overworking of your quadriceps or underworking of your quadriceps. So you need to have a proper balance of firing of muscles in terms of volume, in terms of frequency, and to create a perfect contraction of the speed of the muscle to meet the velocity demand of the movement. That's most important, because if you want to kick a ball or if you want to run fast, you need to have these agonistic antagonistic muscles to work in synchronizations with. That's, if it doesn't, injuries are prone. This is an example. Imagine that you have an hyperextension of an individual who's going to miss a ball. For example, I anticipate I'm a football player. You have a ball coming down towards you, and you anticipate that it's coming at an XYZ speed, at an XYZ angle. You're preparing yourself, and then you're trying to revert the ball to somebody else. I'm going to kick a ball with the knee into extension, making us of a quadriceps to go in for a concentric muscle work to push the ball back to somebody else. Unfortunately, the ball pitches an angle somewhere, or unfortunately, the wind deviates the ball somewhere. You miss kicking a ball, and the knee goes into hyperextension. And when the knee goes into hyperextension, if your hamstring goes in, if hamstring is awake, if hamstring is very smart enough to go in for a reflex contraction, it will suddenly, immediately go in for reflex contraction of hamstrings, preventing a need to go into an hyperextension. That's why you can be able to prevent an ACL. If it does not, ACL goes in for a 6. That's what happens over here. The same thing if you go into, if you have a fast running components also. So if you look into all these components, you always have that, you should always be having synchronization between your agonistic and antagonistic muscles in terms of the strength, volume, and the firing response must be equally matching. Let's have an example of situation A. Let's see a small video clip of situation A, how probably you can understand the problem. Right? This is a small clip that tells you about. I'll again rewind it and you can find his knee goes into an hyperextension and he has an hyperextension injury. That's what has happened over here. That's good. So what has happened over here? Yes, definitely there's a loss of shoe group, extrinsic in nature. That's absolutely fine. Yeah, we have seen it. It goes by upper extension. And probably if the patient or the individual would have got into a fantastic training of a reflex, immediate reflex contraction of his hamstrings, there is a possibility that hamstrings, that knee wouldn't have gone for hyperextension. Although it is quite impossible to look in for theoretical components, but there's a possibility of it. So a poor reflex contraction of the hamstrings because of a low recruitment speed and there's a continuous cortical function and a continuous gastrosoleus function probably could have landed the individual into an ACL most than probably hamstring strain. This is an example we should look in for how we see how we analyze sports injuries. Let's look at a situation B, a similar situation. Right, so we have again a long jump gentleman who runs in for, right? Yes, and you can find he has a fantastic leap and his left his left has gone in for a cramp. Now what's happened over here? So if you look on over here, when he's running, he's having a fantastic velocity. He moves good. The acceleration was fantastic. He's starting a leap. And now when he's taking up a leap, you can find there has been extreme flexion of his left knee complex than your right knee complex. And this extreme flexion of the knee complex was little anticipated by this gentleman probably, wherein he is, because of this, what I would say is the hams was actually over contracting. It is because the quads was not controlling a knee flexion. It was exercises working, but if the quads probably was working by having a controlled flexion, by limiting unwanted speed of movement of the hamstrings, the hamstring fibers might not have gone in for an overriding of it, and you might have not got a cramp. Probably he might have not missed this next chance. So this is what happens over here. If your antagonistic and agonistic synchronized combinations of your muscle work in terms of a volume, firing response, your firing frequency and the firing volume is not synchronizing, then you are more prone for injuries. We always talk about injuries in terms of falls, slips, strains, sprains, but this is again one potential cause of injury which is usually found to be missed. So what is this firing imbalance? Let's understand human body is always balanced. You have a right, left equally balanced for a synchronization of movements. You have an anterior and posterior components of a body is equally being balanced. So naturally, when your body is completely balanced, you also have something called as an agonistic and antagonistic, but it needs to be balanced about it. If you do not have a balance, if a force production is not being properly utilized or transferred, or it's not being dampened, wherein force produced at the part is not being delivered properly, then naturally you have a misuse of a force, and this misuse of a force or non-delivered will create a muscle to go in for either an overaction or underaction, and this may lead you for an injury. It's very essential that you make sure that your forces are being optimally being utilized also, and if it is not being utilized, the injuries are more prone for us. That is an important point. To example is always between your hams and your quads, because these two major muscles are always found to be in trouble, and by and large your hamstring muscles. Why? Let us understand your hamstring quads ratios, the 2:3 ratios. We always knew that your quads are always stronger than that of hamstrings in terms of post production capabilities. Now, when you are using a maximum amount of force by your quadriceps to create a force, you anticipate and you expect the hamstrings to release accordingly. If your hams is not releasing accordingly into a speed, imagine that I'm going to kick from this here. The range taken by you is around 110 degrees or 90 degrees. You complete a range of 90 degrees in 0.5 or 0.6 seconds to kick a ball, and for in that 0.6 seconds of moving a knee joint for 90 degrees, the amount of force created by a quadriceps must be equally released from your hamstrings as an eccentric contraction of work. If your eccentric contraction of work is not releasing, or if it is too much, if the hamstring is too much working, either your quads will not function properly, you will not be able to kick the ball, there will be a slowness in your activities, you will miss a target, or you will be reaching the target faster, you will again miss a target, or probably you will miss and you will be having an injury of either hamstrings or some other problem. So it's essential that you have a balanced muscle development with adequate coordination between agonistic and agonistic muscles in the speed of contraction, and this is what is to be trained. But the question is that, are sports persons being trained? Any sports activity, if you take it for examples, okay, a firing mechanism during your activity of kicking a football, you find that this example tells you that your knee of that's a stance lever stable limb is usually partially flexed, not completely locked enough, which demands a strong quads and a hamstring contraction. You need to have equal